It is time. We would like to get started. 2026 Fukushima Medical University International Symposium on Fukushima Health Management Survey. To begin, we would like to ask Seiji Takenoshita for a greeting. Thank you for the introduction. I am Takenoshita from Fukushima Medical University. Good morning. On the occasion of the 2026 International Symposium on the Fukushima Health Management Survey, I would like to offer a few opening remarks. First, I take this opportunity to express my deepest gratitude to the many individuals who have provided tremendous kindness and support in the implementation and operation of the Fukushima Health Management Survey over the past 15 years since the Great East Japan Earthquake and the TEPCO Fukushima Daiichi nuclear power station. We are also deeply grateful to the many participants from Japan and abroad who have joined us for this 8th symposium. 15 years ago, Fukushima was struck by an unprecedented, unparalleled, complex disaster. As the prefecture's only medical university and as a prefectural university, our institution assumed the historic mission of continuing to safeguard the health of the prefecture's residents. Since then, with the support of many, we have made relentless efforts, repeatedly undertaking new challenges and trials and errors. Underpinning this journey has always been a spirit of envisioning Fukushima's future with a global perspective. Faced with unprecedented circumstances, extensive and prolonged displacement, profound anxiety about the nuclear disaster and radiation exposure, it became clear that relying solely on domestic or Fukushima-based knowledge and networks would not suffice to fulfill this mission. Furthermore, we were compelled to address unfounded rumors and misconceptions surrounding Fukushima. Therefore, we actively expanded our network globally, learned extensively, explored more options, selected what we believed to be the best choices for Fukushima, and sought new solutions by drawing on these experiences. Even now, as we mark the 15-year milestone, the spirit remains unchanged. To realize better, newer, more developmental and sustainable initiatives for Fukushima, and to share the true reality of Fukushima as widely as possible, we will continue to envision Fukushima's future with a global perspective. Specifically, our university is currently advancing collaboration with the International Atomic Energy Agency, IAEA. 2 years ago, we initiated a program where ambassadors from IAEA member states visit our university, confirming our significant role in promoting the medical and healthcare applications of nuclear energy. Furthermore, we actively engage in personnel exchanges, including secondments of our experts in radiation therapy and radiation biology, as well as hosting IAEA Technical Cooperation Fellows at our university. Moreover, in terms of international academic exchange, last year we renewed our Memorandum of Understanding with the Korean Institute of Radiological and Medical Sciences, and we also renewed our memorandum with Wuhan University. Additionally, we have signed a memorandum with the Harvard T.H. Chan School of Public Health to promote analysis of responses and challenges following nuclear accidents. This year, in January, the winter session Fukushima field trip was conducted over approximately 3 weeks. I firmly believe that through collaboration with experts, young researchers, and students, we not only stimulate the exchange of knowledge and technology, but also build a network grounded in a human-centric worldview. Such a network will serve as the driving force to understand Fukushima from a global perspective and to advance our commitment to community-based research and problem solving. We also believe this will simultaneously help convey Fukushima's present as it continues to move forward towards the future to the wider world. We hereby ask for your continued support. In closing, I pray this symposium will be a meaningful occasion for all participants today. This concludes my opening remark. Thank you for your kind attention. Takenoshita Seiichi, President and Chairman of the Board, Fukushima Medical University. I look forward to a fruitful meeting. Thank you.
Director Mr. Takenoshita, thank you very much. Now, we would like to have remarks from the Fukushima Prefecture Governor. And because of the official affair, Mr. Sato, the Vice Governor, will give us a message. Good afternoon, everyone. My name is Sato. I'm a Vice Governor of Fukushima Prefecture. Mr. Uchibori could not attend this meeting, so I would like to read the message on behalf of Mr. Uchibori. I extend my greeting on the occasion of 2026 Fukushima Medical University International Symposium on the Fukushima Health Management Survey. I would like to express my sincere gratitude to all of you for your dedicated effort towards Fukushima's recovery through your research and investigative activities, as well as your exceptional understanding and support for our prefecture on a daily basis. In Fukushima Prefecture, since the accident of Fukushima Daiichi nuclear power plant of the Tokyo Electric Power Company, we have been continuously conducting the Fukushima Health Management Survey with the cooperation of Fukushima Medical University to maintain and promote the long-term health of our residents. As the survey marks its 15th year since the commencement, today's symposium will introduce the progress, achievements, and the challenges of the Fukushima Health Management Survey to date, and open lectures for the Fukushima resident will be also held on the theme more relevant to the lives of the residents. We hope this symposium will serve as a platform to widely disseminate the latest information on the Fukushima Health Management Survey, both domestically and internationally. The prefecture will continue to work closely with the Fukushima Medical University to ensure the safety and the security of our residents. We sincerely ask for your continued support and cooperation. In closing, I sincerely hope this symposium serves as a fruitful event and wish that the continued good health and success of all participants today, including the participants through online. In March 12, 2026, and I read on behalf of Masao Uchibori, the governor of Fukushima Prefecture. Thank you very much.
Thank you, Vice Governor Mr. Sato Hirotaka. For Vice Governor Mr. Sato, he would need to leave due to other priorities. Now, we would like to move on to the speaker from WHO, Radiation Emergency Medical Preparedness and Assistance Network. We have a video message from Dr. Kim Baewa.
Distinguished colleagues, esteemed partners, ladies and gentlemen, it is a great honor for me to speak today on behalf of the World Health Organization as we mark 15 years since the Great East Japan earthquake, the devastating tsunami, and the subsequent accident at the Fukushima Daiichi nuclear power plant. This is a solemn anniversary, one that carries profound meaning not only for Japan, but for the global public health community and for all of us who work to prevent and respond to radiological and nuclear emergencies. Today, we remember the lives lost, the communities disrupted, and the extraordinary resilience shown by the people of Fukushima. We also acknowledge the immense scientific, medical, and public health efforts that followed, efforts that continue to shape global understanding and preparedness for nuclear emergencies. Allow me to pay special tribute to our colleagues at Fukushima Medical University, FMU. Their work over the past 15 years has been nothing short of exceptional. As a member of the WHO RAMPAN Radiation Emergency Medical Preparedness and Assistance Network, FMU has demonstrated unwavering commitment to scientific rigor, transparency, and service to the affected communities. FMU researchers and clinicians have shared their findings openly with the world, often under intense pressure and always with a deep sense of responsibility. Their contributions have strengthened global evidence for radiation health effects, mental health impacts, risk communication, and long-term community support in the period of recovery after nuclear accident. This openness sets a global example for scientific transparency in the aftermath of a nuclear emergency. The lessons from Fukushima are not simply technical. They are human lessons about trust, communication, community engagement, and the importance of listening to people's concerns. They remind us that preparedness is not only about equipment, protocols, and supplies. It is about engaging with the community, about credibility of science and the ability to communicate clearly and compassionately in moments of uncertainty. These lessons are more relevant than ever as we meet today in a world facing renewed geopolitical tensions. We are witnessing increasing pressures on the international arrangements and agreements that have helped for decades to prevent the use of nuclear weapons. Once unthinkable possibility of their use has re-entered global discourse. This reality underscores the urgency of strengthening public health and medical preparedness for nuclear emergencies at all levels, local, national, regional, and global. Fukushima taught us that even in the most advanced and well-prepared societies, emergencies can overwhelm systems and challenge the assumptions. It taught us that misinformation can spread faster than radiation, and that communities must be engaged not as passive recipients of information, but as equal partners involved in decision-making process. It taught us that long-term health monitoring, mental health support, and transparent communication are essential pillars for a recovery. And it taught us that international cooperation is indispensable. WHO remains committed to working with Japan, with Fukushima Medical University, and with all RAMPAN partners to ensure that hard-won lessons of 2011 continue to inform global preparedness. We must translate these lessons into stronger health systems, better trained medical and public health professionals, more robust risk communication strategies, and deeper collaboration across borders and across levels of response. As we honor the past, we must also look forward with humility, with vigilance, and with determination. The people of Fukushima have shown the world what resilience looks like. Their experience, must continue to guide us as we confront the uncertainties of today's global landscape. On behalf of the WHO, I extend our profound respect and gratitude to the government of Japan and Fukushima Prefecture, and especially to the dedicated staff of Fukushima Medical University. Your work has protected health, advanced science, and strengthened global safety. The world is safer because of your contributions. Arigatou gozaimasu.
Thank you very much, Ms. Kenbaeya. Next, we will begin the introduction overview of the Fukushima Health Management Survey. This session will be chaired by Oto Hitoshi from our university. His biography and other details can be found on pages 8 and 9 of the program. Please take it away, Professor Oto. Thank you very much. We would like to start the introduction lecture by Professor Yasumura. As you know, Professor Yasumura conducted the ground design, and also Professor Yasumura has been spearheading this survey. Thank you very much for your introduction. And as an introduction, today I have the pleasure of explaining the overview of the Fukushima Health Management Survey. After my introduction as session 1, the 15 years into the future and the learnings, for each of the specific surveys, there will be clear explanations, and therefore I will be covering the overview of the entire survey. And there are no conflicts and this of interest concerning this presentation, and these are my views. And I will cover these topics. And first, I will cover nuclear disaster after the Great East Japan Earthquake and its impact on people. In Fukushima, Prefecture suffered a severe disaster due to the release of radioactive materials from the Tokyo Electric Power Company's Fukushima Daiichi nuclear plant accident. On the left, you can see how radiation dose rates were recorded across all of Fukushima Prefecture. The red shows higher dose, and on the right, evacuation zones around Fukushima Daiichi nuclear power plant as designated by the central government. In Fukushima, those are the direct death numbers. So compared to Iwate and Miyagi prefectures, it is known to be relatively smaller in terms of numbers. However, disaster-related deaths, those are not directly related to the earthquake, recorded 2,348. So these are relatively high. And also to be noted that there is no death due to radiation has been recorded. And as I have mentioned earlier, in terms of disaster-related death, and there are two different types. So disaster-related death, as well as direct death related to earthquake. And Fukushima has a significantly higher number. And disaster-related death is not directly related to earthquake or tsunami. So that is to say, this is related to evacuation. Their lifestyle may change, and what they have been doing is no longer possible. So their physical and psychological burden is showing on this result. And now the new accident, we have implemented those examinations. And this was held in June, so there were two major purposes. And now the objective is to understand the health status of the residents of Fukushima, and now to protect and promote the long-term health of Fukushima residents. And so this Fukushima Health Management Survey big purpose is to protect and promote the long-term health of Fukushima residents, and we are continuing this survey. And this is a schema of the Fukushima Health Management Survey. The survey includes a basic survey, which is on the left, from Fukushima residents, and this is to show the external dose, and 4 detailed surveys: thyroid, ultrasound examination, comprehensive health check, mental health and lifestyle survey, and pregnancy and birth survey for specific groups. And first of all, I would like to emphasize that all examinations are voluntary. Those who wish to take will take those examinations, and those who do not wish to take those examinations do not need to undergo these examinations. And the details will be covered by the following presentations. But today, in this presentation, I would like to cover the main points. For the basic survey, so this is during the first 4 months after the accident, and 99.8% of the respondents had less than 5 millisieverts, and the median was 6 millisievert, and therefore the actual evaluation, and there is this oversight committee, which was developed by Fukushima Prefecture, concluded that those estimation results obtained from this survey were considered as not being at a level where health effects can be confirmed with a statistical significance in light of scientific knowledge obtained to date. Next is thyroid ultrasound examinations, and these have been conducted for all residents aged 18 or younger at the time of the disaster. Eligible participants were 368,000, and after a preliminary examination, confirmatory examinations are offered to individuals with cysts and or nodules larger than the threshold criteria as needed. And of course, those are voluntary, and therefore the decision to undergo the examination or not should be made after a full understanding of the benefit as well as disadvantages of being examined. And the final judgment is going to be made. And therefore, if this is going to be conducted, informed consent would be obtained. And we have different activities to help the understanding of the examinations. And before I explain the result, so I would like to explain some additional information. We would like to make a comparison. So this is from UNSCARE report, 2021 report. And Fukushima accident shows that of the different scenarios. So individuals will evacuate in different routes, and there are individual differences. However, the minimum is from 2 milligray, and the larger number is 30 milligray. And if you can look at the bottom, the number in Ukraine of the same evaluation was 330 milligray, and Belarus show 1,100. And if you compare the exposure of Fukushima infants is very small compared to that. And based on that, there were many analyses made at the oversight committee. And the views have been reported about 5 times, and the 5th round has been reported. And the recent 25th Thyroid Examination Evaluation Subcommittee concluded that no significant association was recognized between thyroid cancer and radiation exposure. And although the examinations are voluntary, there may be some anxieties even after the results have been reported, and many residents feel anxious undergoing these primary and secondary examinations. And therefore, we provide a variety of supports tailored to participants at each stage. Moving next to the comprehensive health check. And I look at the eligible participants, included about 210,000 residents of 13 municipalities in evacuation zones. So these are the same as other examinations to follow. And you can see that the 13 municipalities residents, so those are the targets. So the total number would be 210,000. And the reason why those residents became eligible is that we needed to examine the risks for disaster-related deaths, and we needed to have special accommodations, and therefore we set those examination items. And I would not go into the full results, but if you can look at the middle, obesity, hypertension, dyslipidemia, diabetes, and cardiology or circulatory diseases risk factors are increasing. And however, the major risk factor for this has been found to be the lifestyle change due to evacuation. And with this, the conclusion is that the comprehensive health check showed no findings or implicate radiation effects in the results of the comprehensive health check. And the overall purpose is to provide proper support to residents based on findings obtained through the surveys. And therefore, we will first like the residents to understand their health situation, and we provide leaflets promoting the prevention of lifestyle-related diseases, and improving lifestyle habits are also distributed to help raise health awareness and enlightenment. And here we are going to discuss the mental health and lifestyle survey. And also eligible participants are 210,000 people. And this survey is conducted through questionnaires specific to each age group. And based on this, we tailor the contents to each individuals. And as you can see, the individual making phone calls as necessary, the center will make phone calls to support the eligible participants. And this is the children's mental health status. This SDQ scores of 16 or higher. If the children score turns out to be 16 or higher, then we are going to provide a support. And every year we see the improvement, and therefore this 9.5% is very close to the national mean, which is a happy result. However, for the case 6, this is for age 16 and above. And this case 6 shows the proportion of people needing support for depression or anxiety. And right after the accident was 14.6%. And however, in the Japanese population, it's 3.0%. And that is to say, 1 out of 3 individuals require mental health support. However, right after the accident, it was 14.6, and it has been improving year after year. However, in the last couple of years, the improvement has been slightly stalled. at a relatively higher level. And so we cannot yet say that a very good improvement has been achieved, and therefore we saw the need to look more closely into this. And most of the people have evacuated, and this shows that residents who were able to get back to their residence and those who did not go back. And the green shows those who live outside of the prefecture, and the blue bar represents those who came back. And from the beginning, those who have evacuated and still live outside Fukushima show higher mental health needs. And therefore, we recognize the needs to provide further support, and especially for those who are at a higher risk. And for those, we, for example, make phone calls, and also we make approaches not only to high-risk people, but we also have initiatives to support the residents of Fukushima Prefecture in general. And this will be led by municipalities, and we are also supporting this activity. And lastly, in order to support pregnant women, a self-reporting questionnaire survey has been conducted every year. And as you can see this in the photo, many specialists have been supporting. And I hope you will remember this result. And for the pregnant, childbearing people, there are three criteria that has to be looked at. And preterm birth and low birth weight or congenital anomalies among newborns in Fukushima Prefecture from fiscal year 2011 to fiscal year 2020. And the important point is that these indicators have been lower than that of national data, or approximately the same. And therefore, we would like to express that Fukushima is a location where people can bear children with a sense of security. And this is the summary of the Fukushima Health Management Center's 10-year report. And not just giving one-sided or one-directional information. We hope the information provision to be bi-directional. And so this communication activity is going to be extremely important, and a serious and difficult problem persists. And this is the number of Tokyo residents who thought it was highly likely or very likely that health effects on the next generation and beyond would occur in Fukushima due to radiation exposure. And in 2017, the number was 49.8%, those people in Tokyo. And this has been decreasing year by year to 31.3% in 2023. But 3 out of 10 people think that in Fukushima there could be some health impact, and there are those who believe in this. And we think this is not this is different from the fact, and therefore we recognize that there are efforts that we need to undertake. And with this, I would like to conclude my introduction. I look forward to a fruitful meeting. Thank you very much.
Professor Yoshimura, thank you very much. So Fukushima is the region, he emphasized that Fukushima is the region where you can comfortably raise your children. This is the end of the introduction part. Then we would like to start the session 15 years since 311, progress through challenges. And the chairs are Professor Ohira and Professor Ikeda. Please refer to the document for the their profile. Then the session 1, that 15 years since 311, progress through challenges. My name is Ohira, and my name is Noriko Ikeda. Nice to meet you all. And without further ado, we'd like to start the presentation. The first presentation is done by the Tetsuo Ishikawa, Professor Ishikawa, and the significant key findings of the basic survey. Please refer to the program for his profile. And thank you very much for your kind introduction. Let me start my presentation. So, considering that the situation after the accident, we saw that that the prefecture, the level of radiation level increased very sharply. So consequently, survey was initiated to obtain information on individuals' post-accident activities and to come up with their external radiation exposure doses. That was planned, and that is called the basic survey. And the people covered are until 1st of July, the residents during that period, and that the people covered was 2.06 million. And these are the main part of the questionnaire sheet. And from the date of March 11, and for 2 weeks till 25th of March, this required the record of the location every hour and whether they are indoors or outdoors, as shown in this diagram. For entries after March 26, the format becomes simpler, asking for information such as place of residence, average daily time spent outdoors, and the workplace and school locations. Then, activity log is to be completed up to July 11th and for 4 months. And people don't recall very well, even if that duration is less than 4 months, and this recording was done. And this survey includes all age groups. Minors must have their questionnaire signed by a parent or guardian before submission. And this illustrates the concept of dose estimation. As shown in the previous slide, location information recorded on the questionnaire shown on the previous slide is covered into the latitude and longitude coordinates by overlaying this data with the spatial dose rate maps on the computer. Individual exposure doses are estimated. And location information respondents are also indicated whether they were indoors and outdoors. Therefore, when indoors, factors such as shielding effect from building are also taken into account. This estimation uses a program developed at the time by the National Institute of Radiological Sciences. This diagram flows a basic survey process. The overall flow consists of 2 main streams: notification of radiation doses to residents and provision of information, and the survey itself to grasp the overall trend. And this flow in the behavior record, it is supposed to be sent via mail, but it's not only waiting for the response, but there are sometimes proactive action to visit the residents and to promote that entry. And this is handwritten, so in order, we needed to digitize that so that computer program can read. And this deficiency, and there may be some deficiencies. And for instance, I was at the relative's house, and it cannot be converted to into the latitude or longitude. So sometimes we made an inquiry to identify the specific location. And for over 60,000 people, we have carried out this kind of program. So digitization of the behavioral response. At the time of initiation, the number of questionnaire was very much. At the peak, we received 8,000 responses per day. So by one, we handled or processed that form. The result is informed to the individual who answered that the questionnaire to date. We have provided about the approximately 555,000 people, including those whose activity records were less than 4 months, and those was informed. Meanwhile, the survey perspective, this estimated dose have been aggregated by region and have been reported and published in papers. And this shows the questionnaire response assistance activities presented on the previous slide. We conducted these assistance activities on the occasion like one shown here, helping with filling out and submitting responses. This photo shows you that. And we have provided this kind of support, and Fukushima's prefecture-wide response rate was 27.75%. However, the examining response rate by municipality reveals significant regional variation. So surrounding area of the nuclear power plant, it is over 40%, and there are 8 municipalities which recorded higher than 50%. However, given that overall response was not so high, so we have conducted the representativeness survey, and because of that, our survey results are not biased. That has been proven. And this is the 4-month comparative data and 25 March. This is as of March 31 of 2025. And the people who submitted the 4-month behavioral record, 467,000. So that most of the people are less than 3 millisieverts. And this is the estimate of the category of the responses and by region. And so area where that nuclear power plant is located, most of the people, dose was below 3 millisieverts. So it is difficult to see the direct impact from the radiation. That was a conclusion by the committee. And so I would like to give you one example. And within 20-kilometer radius of the Fukushima Daiichi nuclear power plant, evacuation order was issued. But the yellow part in 21, after 1 month, and this was identified as a planned evacuation road. It was Itate village and Namie town. And the residents in a planned evacuation zone were generally recommended to evacuate outside of the zone about 1 month, starting from April 22. However, the actual timing of evacuation is likely to be varied by individual. So international organizations such as the WHO and UNHCR have also conducted dose assessment for Fukushima residents. These doses is evaluated on the basis of several assumptions, and for 1 year, that WHO submitted that report first was WHO, and Namie town and Itate city, 10 to 50 millisieverts was the result of the assessment. And this was based on that the very safety side, spending 8 hours per day outdoors for 4 months. However, UNHCR and in that report in 2020 and 21, report presented the estimate and utilized actual evacuation patterns. So as a result of their survey, that the dose was less than 1/10 of the WHO's estimate. So you can see that having the record of the behavior is very important. And since it is time, I would like you to take a look at this summary. Thank you very much for your kind attention.
Thank you, Dr. Ishikawa. Thank you for sharing the importance and the role of the basic survey. We have question and answers to be taken at the discussion time. We have some dedicated discussion time. Now we would like to move on to the FHMS details. The first one is the thyroid ultrasound examination. The speaker is Dr. Suzuki Satoru. Please refer to the profile in the program. Thank you very much for the kind introduction. Let me start my presentation. So it has been 15 years since the thyroid ultrasound examination, TUE, began for children who were 18 years old or younger at the time of the nuclear power plant accident. Today, I will first explain how this program has been carried out from the beginning up to now and what has been learned so far. I will also talk about the efforts to support participants as they grow into adulthood so they can easily access the information they need and make their informed choices. Finally, I will share the key findings and lessons learned from the 15 years of TUE. This is the topics I'll share today. First, about the thyroids, the radiation and the thyroid, and how the thyroid ultrasound examination began and what has been learned so far. And lastly, I would like to give a conclusion. My presentation will be about 20 minutes. Now, first about the thyroid. Thyroid is called thyroid in English, koujousen in Japanese, because the organ looks like a tortoise shell or like a protective shield. The thyroid is an important endocrine gland that makes and releases certain hormones that contain iodine. Thyroid hormones play a vital role. This picture is a tadpole. Tadpole become frogs. Thyroid hormones are essential for tadpoles to turn or metamorphosis into frogs. If tadpoles are administered with drugs that suppress thyroid hormone, or if they are genetically modified to have low thyroid development, they do not become frogs. Instead, they will remain to be large tadpoles. In this way, thyroid hormones are involved in cell differentiation. So what is the role of thyroid in human body? There are mainly two roles. Before birth and during growth, thyroid hormones are important for the development of brain, organs, and bones, including musculoskeletal system. In adulthood, thyroid hormones help control energy use and metabolism in the body. Now, the relationship between radiation and the thyroid. Because hormones are synthesized using iodine, the characteristic feature of thyroid gland is its uptake of iodine. This image shows a photo after administering medical-grade radioactive iodine to human body. As shown in the photo, iodine is largely taken up by the thyroid gland. Iodine is absorbed through inhalation from the atmosphere and also through diet. This specific uptake of iodine by the thyroid led to the development of thyroid cancer in many children who absorbed radioactive iodine after the Chernobyl accident. This represents the increase in childhood thyroid cancer in Belarus. The horizontal axis shows the year starting from the time of the accident in 1986. The vertical axis shows the incidence rate of thyroid cancer. The red, green, and blue lines represent the age at the time of the accident. As shown in red, the thyroid cancer incidence rate began rising around 5 years after the accident for those diagnosed between 0 and 14. While it peaked in 1996 and then declined, a decade had passed from 1986 to 1996. Thus, those who were 0 years old at the time of the accident turned 10 years old by then, and those who were 4 years old were 14 years old. Subsequently, the incidence rate of thyroid cancer began to rise among those diagnosed at age 15 to 19. The peak occurred in 2001, the year when those who were 0 years old at the time of the accident became 15 years old, and those who were 4 years old became 19 years old. Subsequently, an increase in incidence was observed among those diagnosed at age 20 to 24. This pattern indicates that thyroid cancer consistently developed among those exposed at age 0 to 4. Subsequently, the incidence from the red, green, and blue peaks subsided, showing that the incidence decreased among those born later who were not exposed. Now, how the TUE began and what it has found. This is the comparison of thyroid radiation exposure doses from the Chernobyl nuclear power plant accident and Fukushima accident as presented in Ministries of Environment materials. The exposure levels of the Fukushima were estimated to be low, roughly equivalent to the background radiation level seen in Chernobyl. Although the amount of radiation dispersed from the nuclear power plant accident following the earthquake was not expected to be high as that from the Chernobyl accident, thyroid examinations began on October 9, 2011, approximately 6 months after the disaster, to monitor children's thyroid glands. This slide shows the examination process. Individuals living in Fukushima Prefecture who were 18 years old or younger at the time of the earthquake will undergo a primary examination using ultrasound equipment, provided that voluntary consent. Subsequently, Fukushima Medical University will recommend a secondary examination to those deemed to require detailed testing. This will include ultrasonography, blood and urine test, and cytology if necessary upon consent. So these are some photos. To date, 6 rounds of examination have been conducted, with the 7th currently underway. Additionally, examination is performed at age 25 and 30. Approximately 300 cases of thyroid cancer have been detected to date. The left graph shows the changes in the participation rate. The right graph shows the participant rate at age 18 for the 6th examination. Overall, the participation rate shows a declining trend, with a breakdown indicating a decrease starting from the school age group of 18 years and older. Next is the initiative of TUE and the future. This explains the difference between general cancer screening and thyroid examination. General cancer screening has been scientifically proven to reduce cancer mortality rates. On the other hand, thyroid examination, or TUE, are health monitoring tests of Fukushima residents and are not considered cancer screening. These examinations are voluntary and are conducted only for individuals who wish to undergo them after receiving information on both advantage and disadvantages. We will explain the advantage of the examination. If the examination reveals no abnormalities in the thyroid gland, it may provide reassurance and improve the quality of life. Early diagnosis and treatment may reduce the risk of surgical complications, treatment-related side effects, and reoccurrence. Analysis of the thyroid examination results allows us to communicate information regarding the presence or absence of radiation effects not only to the individual and their family, but also to the residents of the prefecture and those outside the prefecture. Next, these are the disadvantages. There is a possibility of diagnosing and treating cancer that will not cause symptoms or death in the future. When cancer or suspected cancerous lesions are diagnosed at an early stage, the prolonged treatment or follow-up may increase psychological burden and lead to social and economic disadvantages. The detection of nodules or cysts that do not require treatment or recommendation of secondary examination or cytology, even for benign nodules, may cause physical strain and emotional distress for the patient and their family. Understanding the advantages and the disadvantages of the test is crucial for making an informed decisions about whether to take them. Therefore, we provide explanation through informational documents, outreach lectures, and more recently, animated videos on YouTube. Additionally, we are implementing the following measures. Number 1, establishment of a call center. Number 2, publication of thyroid newsletter twice a year. Regular updates regarding examinations. Number 3, setup of information booths at public facility. Here we provide explanation of preliminary results and facilitate consultations with physicians. Number 4, establishment of dedicated medical hotline. We answer medical questions regarding results. Number 5, support for examinees and their families by the mental health support team. Number 6, support for patients undergoing treatment or follow-up for thyroid cancer and their families, including peer support. Next, I will focus on 3 key initiatives for future testing and convenience. Ensuring the avidity of medical institutions for TUE, primary examination through a shared use framework, and number 3, online reservation system. This is the map showing the medical institution contracted for thyroid examination within Fukushima Prefecture. Moving forward, as school-age children advance to higher education and graduate, examination sites will transition to public venues and medical institutions. Therefore, we have signed off a contract with medical institutions within Fukushima Prefecture and established agreements. Additionally, an increasing number of individuals is expected to move out of the prefecture. As you can see, the proportion primary examination conducted outside the prefecture has been rising for those aged 25 and older. The number of medical institutions outside the prefecture is also increasing. Having said that, the number of testing facilities remains limited. Therefore, we are introducing a system where medical institutions outside the prefecture without specialist physicians can conduct tests through joint utilization with medical universities aiming to secure a bigger number of testing facilities. And since last year, we have launched an online reservation system for convenience. Now, I would like to share what we learned so far about radiation-related topics. This is the same slide using the Ministry of Environment's material. The exposure levels in Fukushima were estimated to be low, roughly equivalent to the background radiation levels seen in Chernobyl. This shows the distribution of mean thyroid absorbed doses by municipalities as published by the United Nations Scientific Committee on Effects of Atomic Radiation. As you can see, although the estimated absorbed doses are generally low, as shown in the previous slide, regional differences are found. For individuals with thyroid cancer detected through thyroid examination, we analyzed the relationship between those at the 4th percentile and detection rate based on the activity record from their submitted basic survey data. Differences in age and examination interval were observed across each group. In analysis using regional estimated radiation doses, we adjusted for potential confounding factors affecting detection rates. The results showed no consistent relationship between radiation dose and the detection rate of malignant or suspected malignant lesions in any of the analyses, such as the detection rate increased with higher radiation dose. We analyzed not only cases detected through the ultrasound thyroid examination, but also cases from the cancer registries. However, no consistent dose-response relationship was observed. We analyzed estimated radiation exposure doses over time in Hamadori and evacuation zones, categorizing them into 3 groups. Even when adding cases from cancer registries, no consistent relationship was observed. Specifically, in analysis using individual estimated radiation doses, no consistent relationship was observed between radiation exposure and thyroid cancer detected from the initial screening to the 5th screening, or between radiation exposure and cases registered only in cancer registry up to 2019. This means that the detection rate did not increase with increasing radiation dose. The Chernobyl accident showed an increase in thyroid cancer, particularly among children aged 4 to 5 or younger, but no such trend was observed in Fukushima. In the temporal analysis of cumulative detection rate, we confirmed the cumulative detection rate by age group at the time of the disaster. The results show that the cumulative detection rate for the generation aged 4 or younger at the time of disaster did not increase, confirming that the trend differs from what is observed in radiation exposure incidents, such as the Chernobyl nuclear accident. Based on these findings, the summary for the TUE preliminary baseline survey through the 5th round full-scale survey was published last July. Number one, from the preliminary baseline survey through the fifth round, no association between thyroid cancer and radiation exposure has been recognized. It can be said that this conclusion is clearer than at the stage of the summary up to the fourth round full-scale survey. Regarding the region-restricted analysis in case control study, the results have not been consistent, possibly due to the small number of covered population included in the analysis. Therefore, it remains important to make judgment based on the results of continued follow-up analysis. Number two, in the summary through the fourth round survey, it was stated that the results of the detailed ultrasound examination conducted on a broad population of asymptomatic individuals may reflect either an overdiagnosis of cancers that do not threaten life expectancy or cause symptoms, or the early detection of cancers that may cause symptoms in the future, or both. And at present, it is impossible to determine the relative proportion of these effects, and further retrospective verification by specialized academic society is necessary. This assessment remains unchanged at this time. Number three, TUE program has been conducted with the aim of long-term monitoring of children's health based on the intention of residents who seek to undergo the examination. The program should be implemented in a manner that enables residents to make informed decisions based on sufficient information. Now, we would like to share non-radiation related learning so far. As you can see, new knowledge about the thyroid glands has been revealed. Due to the time constraint, I will discuss only number 1 and number 5 today. First, regarding the thyroid size. The left column shows sizes by age group based on the ultrasound measurement, while the right column shows sizes by body surface area for women and men. Measuring the thyroid gland size can be particularly challenging, especially in children, when determining its vertical length. We have established a simplified method to evaluate thyroid size. Clinically, this has enabled the standardization of thyroid size, the calculation of standard deviation score, SDS. Finally, regarding diffuse enlargement and thyroid autoantibodies. This table shows age on the horizontal axis and the frequency of diffuse thyroid enlargement on the vertical axis. Black represents male and red represents females. The frequency of diffuse thyroid enlargement increases with age, and except for age 1 to 4, female generally showed a higher frequency of diffuse thyroid enlargement than male across all age groups. Epidemiological findings from these incidental findings provide valuable information for the clinical interpretation of both physiological changes in the thyroid gland developing from childhood to adolescence and pathological changes including thyroid autoantibodies and papillary carcinoma. Finally, starting with the thyroid gland, a hormone-secreting organ, and hormones, we have looked back together over the past 15 years at the progress of prefectural health survey. Thyroid examination, covering its overview, our efforts, and the various findings revealed. This was an unprecedented examination, but we have been able to continue implementing it to this day while receiving diverse opinions. Moving forward, we will continue to ensure voluntary participation, obtain the understanding and consent of all participants, and facilitate smooth access to the examination for those who wish to undergo it. Thank you for your attention.
Thank you very much, Dr. Suzuki. The questions will be entertained at the discussion session later. We would like to move on to the next session, which is the comprehensive health check, what we have learned over 15 years and what lies ahead. We would like to hear the presentation from Dr. Shimabukuro. The floor is yours. Once you're ready, please start. Thank you very much for the introduction. And this is Shimabukuro. I'm going to discuss this topic, the comprehensive health check, what we have learned over the 15 years and what lies ahead. I am going to discuss those three topics. First, lessons from 15 years of the comprehensive health check. And these are the basic schema, and it includes 5 surveys, and this is the third component. And these are the non-communicable diseases which increased after the disaster. On the left-hand side is under 15 years of age. The right-hand side is 16 years and over. And what would be the issue here would be vertical obesity and the high TG and low HDL. And on top, we have the risks related to obesity. And at the bottom, we have non-obesity related risks. And what are underlined in orange are the ones that have increased. And in under 15 years of age, dyslipidemia increased. And over 16 years, obesity and also obesity metabolic syndrome, as well as hyperuricemia, increased. And as a result, CKD, as well as stroke and heart attack, heart failure, and also diabetes due to the aggravation of these conditions. And to summarize, in children, those conditions in orange have increased, and in 16 years and above, those orange ones increased. And I did not mention earlier, but polycythemia also increased. And what is important here is that the leukocyte, as well as its fraction, did not show any change there. That is to say, the direct impact of radiology has not been confirmed here. And on the left-hand side, and there are many lifestyle-related factors as well as disaster-related factors. For example, work change as well as evacuation or any mental or trauma responses. And when there are such factors, then non-communicable diseases could be impacted. And we also can see the gender differences. Red arrow shows increase, black arrow shows decrease, and empty spaces indicate no change. And what stands out here is obesity and the increase in hypertension, diabetes, dyslipidemia, abnormal liver function, and impaired kidney function for both men and women. And also hypertension and abnormal liver function due to current alcohol consumption or evacuation can result in some of the increases in some conditions. And also mental condition or changes will impact some of the conditions. And this is what we can see from here. Next, I would like to discuss non-communicable diseases and evacuation and psychological burden. And there are two ways of estimating psychological burden. The first method is Kessler-6 scale, we call K6 scale. And it asks questions about whether the individual feels nervous or hopeless and other factors. And there are 6 items that are being asked, and the scores are given. And the full score is 24. And if the score has 13 points or higher, then it can be seen that there is psychological burden, and this has been used internationally. And this shows how much people are having this 13 points and higher. And one chart shows the United States residents, and D shows the result of Ministry of Health, Labor and Welfare Basic Survey on National Living Conditions. This is a representative result of the Japanese residents, and it shows that the score of 13 and above is very low. And the other methodology is the traumatic reactions, and this also shows the score and distribution of those scores. And this is the result of the American people after the World Trade Center incident. And we can see the frequency of the people found to have traumatic reactions. And this shows the comprehensive health check result. This is on top is K6, and at the bottom is PCLS. This is the traumatic reaction. And at the bottom, you see those who developed diabetes, and the red is those who had the K6 positive result. And we have both gender, men and women results. And as you can notice, when it is below 0.05, there is a difference. Clearly, men have with those with psychological burden are developing diabetes, and there's no difference seen in women. On the other hand, for traumatic reactions, men, if they are found to be positive, they are developing diabetes, and also some women develop diabetes. And moving on, so those people with diabetes tend to, or those with psychological burden tend to develop diabetes, and with diabetes some complications happen, and in the worst case it can lead to death, and that is the problem. And the respondents of the comprehensive health check, and among those who passed away, whether diabetes played some role in it is shown in here. And here all death is 1.46 times, and so this is in women it's 1.39, and in women it's 1.57. And so we can see that even if an individual evacuated or not, with diabetes the ratio will increase. And another important point that have been found is that with myocardial infarction, those who did not evacuate, even with diabetes, the number has not increased. On the other hand, for those who evacuated, have increased by 2.56 times, or 2.34 times, or 3.03 times. And it is the same thing for stroke as well. And for the cerebral infarction, there could be hemorrhagic death and non-hemorrhagic death. And so these are just estimates, but for those who did not evacuate, most likely they might have been able to undergo treatment. And if they have been treated, then we don't see the impact of diabetes. But those who did evacuate, so there could be other factors playing into this result. And finally, I would like to discuss how we consider the future from CHC. Non-communicable diseases, I would like to discuss who is going to prevent and how those non-communicable diseases occur. And first of all, lifestyle habits like smoking or unhealthy choices, as well as inactivity, will lead to non-communicable diseases or lifestyle-related diseases, and cardiac diseases or renal diseases, as well as heart failure, and this can shorten the healthy lifespan. And what is important here is that lifestyle as a background, there are environmental factors as well as stress coming from, for example, war, and those factors are very important to be considered. And for these, on the individual level, as I have mentioned, even with diabetes, if measures have been taken, then it is possible to mitigate the impact. And this has been found both domestically and internationally, and therefore correct measures have to be implemented. And therefore, knowledge also would be important, which means that literacy is important. On the other hand, there are individuals who can successfully address the issues and who are not so successful. And therefore, in government and community level, as well as smaller community levels, and this symposium is one of those efforts, communicate data to those individuals is important, and also show what kind of measures can be taken, including what I'm communicating today. And this kind of measures are important. And this comprehensive health check within this Fukushima Health Management Survey plays such a role. And as I have mentioned earlier, so those conditions that have increased due to the earthquake, what are we going to do? And those mentioned in blue shows what we can do, and because those have evidence of prevention as well as treatment. And as we can see here, to each of the risks, there are effective measures that can be taken, and therefore it is important to encourage individuals to implement those measures. And this is my summary. And what we have found from 15 years of CHC, there are increased in adults and especially in children, different conditions. And also, so those are not found to be the direct impact of the doses, but so those are presumably the evacuation and lifestyle related changes as the most important factors. And also there are gender differences, and especially we can see the higher onset in men. And considering the future from CHC insights, as I have mentioned earlier, and there are increase in diabetes as well as cardiovascular diseases, and we can expect the increase of these going forward. And therefore, individuals and communities must learn healthy literacy and apply correct health knowledge. This concludes my presentation. Thank you very much for your attention.
Professor Shimabukuro, thank you very much from that physical check and from the past 15 years and what to do for coming 15 years was discussed. Now, and the next speaker is the Professor Naoko Horikoshi, and the Mental Health and Lifestyle Survey, looking back the 15 years, is the title of her presentation. Please refer to her profile in the program. And my name is Horikoshi from KOKOKARA survey, Mental Health and Lifestyle Survey. So, reflecting on 15 years of mental health and lifestyle survey activities for the disaster-affected people is the title of my presentation. There is no COI, and so the overall overview of the survey. First, the overview of the survey. A purpose of this survey is long-term tracking of the mental health and lifestyle issues among disaster victims through questionnaires, so that to provide the outreach-based support. And it is both a survey and the support. And the people to be covered are the participant, also the residents in that zone, about 190,000 people. That questions are segmented in 5 areas, and individually we have conducted the survey, and from 2011 to present, every year we have continued this survey. The result of the survey and the trend of the high-risk rate of the emotional and behavioral issues among children aged 4 years and older, and 9.5 high risk among the children affected by the disaster. Immediately after the earthquake, there was was very high, 24.4% from age 4 to 6. Then the rate decreased across the age group, showing the trend in improvement. But it's been 15 years. We have more children not having experienced that disaster. And next is the result of the general adult population. This represents the percentage of risk individuals, like experience of depressed mood and anxiety, compared to a high-risk rate, which is 3% in a non-disaster area. For the immediately after the earthquake, it was 14.6%. The high-risk rate increased during the COVID, but there was not drastic increase. Compared to the age 65 and above, the high-risk tendency was higher among the age 16 to 39. The next is the frequency of regular exercise, and 43.9% have exercised at least twice a week, and it's been improved gradually. But because of the COVID-19 in 2021, that rate dropped once. And compared to the nationwide survey, we cannot compare apple to apple, but this habit is comparable to the national level. And also next is problem drinking. And the percentage of problem drinking is going down, both men and women. And also the awareness, perception of radiation risk. So about the high or very high on the impact of the next generation, 19.7% is going down every year. But based on the other survey, various indications are showing the improvement trend. However, some indicators remain high levels, and it is considered it is necessary to continue monitoring the situation going forward. And next, I'd like to talk about the telephone support. We select individuals for support based on the service result and provide outreach-based telephone support to individuals, not like that lifeline, but the outreach type of support. And the strength of that is that regardless of the consultation base, the people who cannot ask for help can be reached. And also from the survey result, we know that situation. So early stage, it is likely to, we can easily access the real problem, and we can provide a quick support. And they are composed of a lot of professionals. And also, as necessary, the regional resources are referred to. And so far, we have provided such support for over 40,000 people. Over 15 years, the contents of telephone support has been diverse. Right after the disaster, the contents or the amount of drinking went up, and because of the evacuation, the children had a lot of questions about the radiation, and they had a hard time going to school. And we have also supported the trauma the situation, that the people who are suffering with family members, and they cannot talk about the evacuation to the close people. And recently, the COVID and Noto Peninsula earthquake are the recent incidents, and we've been supporting the people along with these events. We are also conducting survey to evaluate the usefulness of the telephone support. And satisfaction level is 74.6%, which is high. And empathic communication is demonstrated by the telephone support. And also, we only have a limited manpower, and every year we are providing the 3,000 people, the support for 3,000 people. Because of this outreach type support, it should be a useful case for the future event. Now I'd like to talk about the KOKOKARA survey initiative. And we conducted interviews in fiscal year 2014. And as a result, the reason they answer that the question, they want their information to be useful, and they wanted to express their feeling. And the people who didn't answer, and they felt it is not necessary for me, and there are many questions, or it was too stressful to fill in the answer. And we also asked for the improvement and to reduce the number of questions, and also the result of the response should be notified, and please, and also some benefit by answering the question. And also the online response was also requested by many responders. And these candidate opinions were very useful, a source of information for us. Based on the feedback from the disaster victims, we have worked to enhance trust in the survey and improve the implementation. In 2014, we began sending individual result notification letters. Starting in fiscal 2016, we started online. So we used online and paper both. So from PC and smartphone, the answer can be easily given. And also, we also simplified questionnaire was introduced in 2021, and in 2025 marks the 15th anniversary milestone, and we increased the number of questions. So, and we have conducted an event to provide the specialty product from 30 municipalities. This is a result notification since year 2014. Based on the questionnaire responses, it outlines that the respondents' mental and physical condition both in the previous year and current, and it's sent back to the individual. And by providing a specific, easy-to-understand advice for each result, respondents can understand their own health issues and reflect on their daily life and actions. We hope this will encourage them to reevaluate their lifestyle habits and begin taking the step forward, improving their health. And it's a newsletter, and from the interviews we have conducted, the people who didn't answer the question, they may have a high risk of the psychological stress. And it is difficult to provide the support to them. So, KOKOKARA survey, a dedicated dial number was provided. So we are also accepting the telephone call consultation from them. And to cover the seasonal photos from 13 municipalities, KOKOKARA is also sent. The cover features seasonal photos from 13 municipalities in relay format, and it has been well received, particularly those evacuated outside the prefecture who expressed fond memory of their home. And furthermore, and the people who need advice, who we determine need advice, we provide the various contact points and exercise and diet. KOKOKARA survey self-support book is also sent out to those individuals. And what's most important is that the collaboration framework with the various support organizations to ensure other agencies to understand the survey context and objectives we present active reports and coordination meetings and directly visit 13 municipalities regularly. And also, when that booklet is distributed, we handle the news on the municipalities, and also we are proceeding with the collaboration, which shows the strength of each organization. Through these efforts, we have established a seamless support system that provides uninterrupted assistance to disaster victims facing difficulties. Summary: this survey began with a dual focus on research and support. While mental health among children and adults has significantly improved and compared to the first year, but adult rate remained higher than national average. Meanwhile, lifestyle habits such as exercise and routines and problematic drinking show gradual improvement. And 15 years have passed after the disaster. There are some changes of the content of the telephone support consultations. We have continuously provided support tailored for each year, and so far we have covered 14,000 individuals. There are some usefulness proved. And KOKOKARA survey started from 2011. Along with other organizations, we would like to continue to hear the feedback so that our activities can continue to improve. Thank you very much for your kind attention. Thank you very much, Professor Horikoshi. The trend from the survey and the outreach type telephone support, including the people who cannot voice out, there are many support from their side. Thank you very much.
Next, we would like to invite Dr. Ishii Kayoko. The title is 10-Year Pregnancy and Birth Survey Results and 4-Year Post-Disaster Follow-up Findings. The floor is yours. My name is Kayoko Ishii. Today, I would like to talk the 10-year pregnancy and birth survey, as well as the follow-up survey of those who responded to the survey up to the 4th year, 4 years after the disaster. I have no conflicts of interest to disclose. The Pregnancy and Birth Survey is one of the detailed surveys of pregnant and postpartum women. It was carried out every year for 10 years and included about 10,000 women who were pregnant or gave birth in Fukushima Prefecture. We asked about their age and medical history, experiences during pregnancy and childbirth, their children's health, and their child-rearing situations. We also provided telephone support based on depressive symptoms and free comments written in the survey. The response rate for the main survey was roughly 50%. The follow-up survey was conducted among participants who responded to the main survey up to 4 years after the disaster, and the response rate was around 40%. First, I will present the results related to physical health. This slide shows the rate of preterm birth. A normal pregnancy lasts about 10 months, and preterm birth means that a baby is born earlier than the due date. In our survey, the rate ranged from 4.4 to 5.6%, which was similar to the national average. Next, I will talk about the rate of low birth weight infants. Babies usually weigh around 3,000 grams at birth, and low birth weight means a birth weight of less than 2,500 grams. In our survey, the rate ranged from 8.1% to 9.8%, which was similar to the national average. Finally, I would like to talk the rate of congenital anomalies. Congenital anomalies are physical anomalies that occur before birth, and according to obstetric guidelines, the expected rate is about 2 to 3%. At the time of the disaster, there was concern that the number of babies with anomalies might increase, but our results ranged from 2.19 to 2.85%. This means that the rate of congenital anomalies was not higher than expected. We also examined the effect of external radiation exposure. External radiation doses during the first 4 months after the disaster were divided into 3 groups: less than 1 millisievert, 1 to 2 millisievert, and 2 millisievert or more. We analyzed whether these dose levels were associated with preterm birth, low birth weight, or congenital anomalies, but no significant difference were found. In other words, at the exposure levels experienced in Fukushima Prefecture, we did not observe effects on mothers or babies, regardless of the area where they lived. Next, I will present the results related to mental health. In this survey, we used a method to assess depressive symptoms. Participants were asked 2 questions about, over the past month, whether they had been feeling down or depressed, and whether they had found little interest or pleasure in doing things. If a participant answered yes to one or both of these questions, she was considered to be at risk of postpartum depressive symptom. In fiscal year 2011, the proportion of women with depressive symptoms after childbirth was 27.1%, but this rate decreased over time. To allow comparison with national data, we converted the results from the 2-question screening into estimated based on the Edinburgh Postnatal Depression Scale. By fiscal 2020, the level of postpartum depressive symptom had decreased to the national average. At the time of the disaster, about 60% of women in the Seoul region, which is close to the nuclear power plant, were evacuated. By fiscal year 2020, the proportion of people who were still evacuated had decreased to 1.2%. When we divided participants into 2 groups, those who were still evacuated at the time of the survey and those who were not, we found the postpartum depressive symptoms were more common among women who were evacuated. Prolonged evacuation and ongoing concern about the effects on their children may have contributed to the higher rates of postpartum depressive symptoms. Next, we compared women who switched from breastfeeding to formula because of concerns about radiation with those who use formula for other reasons. We found that postpartum depressive symptoms were more common among women who stopped breastfeeding due to radiation concerns. At the time of the disaster, it was reported that intake of radioactive substances above the safety limit was extremely rare, and there was no need to stop breastfeeding. However, some mothers still chose to stop breastfeeding. Next, I would like to talk about the proportion of mothers who lacked confidence in child rearing. The proportion of Fukushima was almost the same as reported in the national survey. For immediately after the disaster through fiscal year 2020, this proportion showed little change. We also examined the associations between confidence in child rearing and evacuation status, as well as the use of formula due to radiation concerns, but no significant difference were found. Taken together, these findings suggest that although the disaster affected mothers' emotional well-being, their confidence as mothers was not diminished, reflecting the resilience and strength of mothers. Next, the proportion of mothers who did not wish to become pregnant again gradually increased from immediately after the disaster. Factors associated with not wanting another pregnancy common to both primiparous and multiparous women were older age at pregnancy, depressive symptoms, and poor self-rated health. Among primiparous women, additional associated factors including using formula because of radiation concerns, having a child with congenital anomalies, dissatisfaction with obstetric care, and living separately from a partner. Among multiparous women, having undergone infertility treatment was associated with not wanting another pregnancy. Overall, we found that mothers who gave birth soon after the disaster had higher depressive symptoms and greater anxiety about radiation. Based on these findings, we conducted follow-up surveys at 4 and 8 years after childbirth among women who responded to the main survey up to 4 years after the disaster. Mothers who gave birth soon after the disaster continued to show higher levels of postpartum depressive symptoms both 4 and 8 years later, indicating the need for long-term follow-up and support. Fiscal year 2020 coincided with COVID-19 pandemic. Mothers who gave birth in 2020 showed low levels of depressive symptoms, whereas mothers who gave birth after the disaster showed increased depressive symptoms 8 years after childbirth. Comments from mothers concerned about COVID-19 included reduced communication, worries about their children's development, concerns about breastfeeding, and financial anxiety. These concerns were similar to those reported during the radiation disaster, suggesting that the COVID-19 pandemic may have reactivated disaster-related anxiety. Next, we divided mothers into two groups: those who had no depressive symptoms shortly after childbirth but developed depressive symptoms 4 years later, and those who had depressive symptoms shortly after childbirth but showed improvements by 4 years. The new onset depression group more often reported poor health, a history of treatment for mental health problems, low confidence in child rearing, and concerns about radiation leading them to not wishing for another pregnancy. In contrast, the recovery group more often reported very good health after childbirth, no history of mental health treatment, confidence in child rearing, and a desire for another pregnancy, and that they had received sufficient care during childbirth. In the follow-up survey at 4 and 8 years after childbirth, we assessed concerns about the effect of radiation. The most common concern was children's health. Concerns about children's outdoor play, water, food, and health decreased over time. According to the Ministry of Environment, no genetic effects transmitted to the next generation have been observed among atomic bomb survivors. However, concerns about genetic effects and social stigma show little change, indicating that anxiety about long-term effects is difficult to resolve. Finally, I will introduce our telephone support program. Telephone support was provided to women who showed high levels of depressive symptoms or were considered to need support based on their free text responses. These are the characteristics of women who received telephone support in fiscal year 2011. They were more likely to be first-time mothers, to live in evacuation areas, to have missed regular prenatal checkups because of the disaster, and to use formula due to concerns about radiation, to have had cesarean section, and to have child with a congenital anomaly. Overall, these findings indicate that even in emergency situation, it is important to provide not only radiation-related support, but also same types of child rearing support as in normal times. These are the main topics discussed during telephone support. Concerns about radiation gradually decrease, while consultation about mothers' mental and physical health in child rearing become more common. In summary, no significant association was observed between measured radiation exposure and adverse prenatal outcomes in this survey. However, psychological impacts, particularly postpartum depressive symptoms, increased immediately after the disaster. Although depressive symptoms gradually declined, follow-up surveys showed a resurgence during the COVID-19 pandemic among mothers who gave birth after the disaster. Even 4 and 8 years after childbirth, concerns about radiation-related genetic effects and stigma persisted among those who gave birth after the disaster. Even during disaster, not only disaster-specific care, but also routine child-rearing support is essential. Thank you. Thank you very much, Dr. Ishii. So it's been the concerns immediately after the radiation exposure and COVID-19, and you have been very empathetic in your activity. Thank you very much for sharing the results.
It is time. We would like to start the discussion session. And Dr. Ohira and Dr. Ikeda to chair. Thank you very much. Please proceed. So this is a discussion session. We are going to address the questions that have been received up until now. And we are going to ask each presenters to answer the questions. And we are going to ask questions in order, and we will be rotating the number of questions. But due to time, we may not be able to answer all of the questions being asked, and those will be addressed within the homepage. And we would like to start the first question to Dr. Ishikawa.
Regarding the basic survey, the duration was from the incident till the July 1st. But the radiation level in Fukushima continued for a while. So didn't you see the need to continue the survey after July 1st? Thank you for your question. And for this, there are three things, three reasons that I'd like to explain to you. The first reason is that the time they remember the incident for the 4 month, it is difficult to remember that the behavior and write that. So if the time prolonged, then it's difficult to recollect. And the second reason is that this survey, and we distributed the questionnaire sheet from the end of June. So if that duration is extended to August, for instance, then they have to wait until the end of the August to submit the record of June. So, and the third reason is that in September and October, then the municipality levels, that the personal dosimeter investigation or survey started, and the dosimeter survey started, then to a certain degree that the external dose rate can be monitored. So that's why we decided to spend 4 months.
Thank you very much. There is a question to Dr. Suzuki about thyroid examinations. In the future, what are the cancers that will not cause death or symptoms in the future? And what happens when those cancers are treated to the body? Thank you very much for your question. Those are cancers. Therefore, it is natural that one would think that there may be impacts on the body. But the answer to this question is that those are cancers that progress very slowly. For example, when cancer occurs in thyroid, when there are effects that can block, for example, the blood vessels and other vessels, then symptoms may appear. But those cancers that do grow, however, would not have impact on the surrounding tissues or vessels. When those are diagnosed, those can be considered as overdiagnosed. And the impact of treatment of those cancers is that when thyroid is removed, one may have to keep on taking thyroid hormones through the rest of the life. And in Fukushima Prefecture, when a part of thyroid is operated, some cases can be considered as cured without any hormonal treatments. Thank you for your question.
Thank you very much. The next one, to Professor Shimabukuro. Along with the evaluation that the mental stress, what is the mechanism of affecting the body from the mental? And also, with this result, that the correlation was more strongly found among women than men. Could you elaborate on that? When you feel the stress within the body, that the hormone caused by the stress will increase. And also it can induce the disease. And gender difference. And in the prefectural health management didn't do the investigation. This is an estimated one. And stress, we checked the stress score. And women has more can easily express their feeling and than men. And also the response to the stress has a gender difference. And that the women have higher communication capabilities. They have more friends. And in case of men, it's more difficult, and that can more easily affect the body. And that's all for me. Thank you.
Thank you very much. Moving on to Dr. Horikoshi of KOKOKARA survey. The question is this. So with time, with the passage of time, I think that people do get to the life in the evacuated areas. But after 15 years, what are the psychological and physical burdens on the people who are evacuating, and what have changed since right after the disaster? Thank you very much for your question. Right after the earthquake, with the evacuation that needed to be done right after the earthquake, work must have changed, and community must have been drastically changed, and family members needed to live in different areas, and therefore the life itself changed drastically, and therefore people having trouble falling asleep and palpitations and that kind of acute stress symptoms have been experienced. And after 15 years, in these days, the initial strong anxiety has been somewhat calmed in some individuals. However, with prolonged evacuation, chronic stress may occur, and also the sense of isolation can be another issue, and those have been found in telephone support as well as text responses in the surveys. And there are young people who cannot say that they are evacuating, and there are those who cannot mingle to those communities while evacuation. And for me, what I think is important is that individual circumstances vary, and therefore those who have been successfully establishing the new life in the new community do exist as well. So I would say that there are individual differences, and therefore we need to provide support catered to each individual circumstances, and this will continue to be important going forward as well. Thank you very much.
Now, a question to Professor Ishii. The depression after the delivery of the baby. So I think in a normal state, there are people who are struggling the depression, and is there any specific feature during who experienced that disaster? The depression you generally have the same symptoms. The depressed feeling, and also no interest for the things, and they cannot enjoy fully. These are the main symptoms. And the pregnant woman who experienced the earthquake, there are some distinctive features as presented because of the radiation. Whether the radiation has any impact on their babies. And because of the evacuation lifestyle, there is a sudden change of the lifestyle, and that is the typical background that affects the pregnant woman during that evacuation life, and the prolongation of the evacuation life and the individual changes are the important factor to provide the support. I understand. Thank you.
Thank you very much. We would like to go back to the basic survey related questions. There are many questions to Dr. Ishikawa, and some of the questions overlap in terms of content, and therefore we would like to ask one straightforward question. Why has the survey for the internal exposure not been conducted? Thank you very much for your question. For this, the assessment of the dosage of the residents is not only carried out by the FMU. However, this has been conducted by different entities. For example, for internal exposure, the examination using full body counter, this has been conducted by municipalities of Fukushima Prefecture. And for 4 months and onwards, the external exposure, the individual dosimeters have been loaned out to the residents. And also the thyroid internal exposure has been assessed by the Ministry of Environment's projects, consignment projects, and therefore, rather than FMU doing all of the assessments, many entities are undertaking different assessments, and we do indeed leverage the results by other entities, but please do understand that the different entities are partaking in different assessments. Thank you very much. So in FMU mainly undertook the external exposure assessments, and the other results are also being leveraged in research.
Regarding the thyroid examination, and this is a question to Professor Suzuki. Nationwide, the examination for thyroid is can be done, and isn't there any differences or among such examinations? Thank you very much. And outside of the prefecture, the number of sites which can do the thyroid examination is limited, so we need to increase such number. But the primary examination, all of the medical sites or the medical institutions, the image and ultrasound results are sent to the Fukushima Medical Universities. Therefore, there will be no qualitative differences as a result or interpretation. So there is no major difference of the quality of the result.
Thank you very much. Another question is to Dr. Shimabukuro related to comprehensive health check. And going forward, for example, lifestyle improvement support, municipality collaboration would be even more important. And what are your plans for that? And related question, for important information to be communicated securely to the participants would be important. What are the plans for that? Thank you very much for your question. So, non-communicable diseases or lifestyle-related diseases are on the rise, and renal diseases as well as cardiovascular diseases are on the rise. And the reason for that can be thought that, for example, lipid and blood pressure and also the blood glucose. And when those risks increase, the entire risk will increase. And therefore, it is important to communicate the results to the participants. And of course, we do that. But just by looking at the result will not mean that individuals will understand what to do. And therefore, those municipality, for example, public health nurses, we should communicate that those public health nurses and other individuals in the municipality should be informed about the result so that they can provide individualized assistance to the participants. And we have to tell the participants that. And another important thing is that the participation rate has been decreasing compared to before, and therefore we have to encourage the municipalities and administrations to encourage participations in those surveys. And we have been working on this topic, but we have to strengthen the collaboration. Thank you very much. That is to say, how we are going to share information about the CHC to non-participants are also important. Thank you very much.
And Professor Horikoshi of KOKOKARA survey, the telephone support And K6 high-risk percentage people, what do you see as a valuable thing or significant thing for the people who had a high score? And to any type of the individual, the comfort of we are trying to be empathic so that we are ready to listen to the individual. But depending on the people, there are some people who are not aware of that SOS signs within themselves. They do more than they should. So that the state of the mind and the sleep conditions and other situations, we try to get such information in advance. So especially the people with high risk of the mental conditions, we think it is important to not to miss that the crisis situation. So if necessary, we can tell them that the indication of when to have a consultation, and also watch kind of program that we can closely monitor the condition of the patient. We are doing that, not only listening, but to depending on that situation the individual is in, you make the right approach. And also, as Professor Shimabukuro was saying, that you also need that need to expand the support which is appropriate for such individual.
Next, a question to Dr. Ishii. We understand that prematurity and congenital anomalies did not show increase right after the earthquake disaster. However, those who have been infants during the earthquake disaster and who have grown up in the low-dose environment, do you expect any genetic impact to be existing? And are you going to conduct a survey related to that? Thank you very much for your question. And I did touch upon this point during my presentation. And those who have been children during the time of the disaster and what are the genetic impacts, according to the Ministry of Environment's document, the gene abnormalities have been looked at, and the children born from exposed parents and those who have been born from non-exposed parents, and there was no change in the chromosomal changes. And in other surveys, the possibility of children having cancer after being born from exposed parents show that there's no clear correlation between those. And going forward in our pregnancy surveys, when the children grow up and to the generation even after that, so the generation of grandchildren, so in those grandchildren generations, in terms of surveys, we are now considering whether we should be doing this or not. And thank you very much, and we should pay attention to the proceeding information. Thank you very much.
Going back to the basic survey, Professor Ishikawa, and the external exposure rate. And in this presentation, what was the new learning or knowledge that you presented? Thank you for your question. In the basic survey, that the behavior record is asked to be put. And based on that, we do calculation of the dose. But recently, the number of respondent or responses is going down, especially the distribution of the dose. We don't have new knowledges very much. That is to be honest. But regarding the basic survey, that looking at the answers from the residents of the prefecture, they understand, they have heard of that, but they don't know much about the content, and they don't know the basic surveys going on. There are many such people, and for the people who heard about the lecture on that, and the people may feel the presentation may be very similar to the last one, and that may be true. For the people who know about the basic survey, probably this presentation, the presentation I made this time was not good enough, but in terms of the percentage, in terms of the people, I understand the majority of the people have not much knowledge of the basic survey. So our main focus was those people. And please understand, that's the main target of our presentation. Thank you very much.
Thank you very much. A question to Dr. Suzuki about thyroid survey. What are the structures to give ample information to the participants who have grown up? So this is a question to the presentation today. Thank you very much for your question. So at the time of the start of the survey, they have not yet attended school for some of the participants, and therefore what we focus the most is that why we are undertaking such surveys, and in order for people to have a better understanding of the reasons, we had elementary school version, and this is what we used to have, and middle school version of the explanatory brochures about the examinations. And so this is what we did. And also we had outreach activities. We went to schools to provide classes, and we also gave medical information and information about thyroid, and those are the activities that we have been undertaking. However, these activities are not sufficient to make people interested in our activities, and therefore, as we have screened those videos, we used anime videos or YouTube to communicate the advantages and disadvantages of the examinations. Thank you very much.
And because of the time constraint, this will be the last question. And this is a question to Professor Ashima Bukuro. The 15 years of the health management survey, if you find the challenges, how do you utilize those challenge learning well for the future actions? And historically, and there was no experience of doing the survey or research on that lifestyle-related diseases in that disaster period. Change of the lifestyle gives that great impact on the people's life, and how to convey that message to the residents. Maybe this explanation was not good enough, and it is difficult to. We cannot say in a forcible manner, why don't you do that and do that? But once we get more friendly, with, for instance, the outpatient, we can gradually say that, but we would like to find out some way to really convey such necessary message going forward. Thank you very much. Through this discussion, you may have thought about the various things, but in 10 years, that impact on the mental conditions and the physical condition may have been revealed, and how to connect these learning for the future initiative should be also important. I'd like to ask one word from you.
Thank you very much for the many questions, and unfortunately we could not answer all of the questions, and I personally feel bad that we did not get to respond. However, we are going to put on our homepage the questions, major questions that have been asked, as well as the answers to these. And the reporting of those 5 surveys, and so we were able to connect those threads going to the horizontal direction as well as those coming to the vertical directions, and we were able to see those cross each other. And in this manner, we ask for a continuous support to these activities. Thank you very much. And with this, we would like to close this session. Thank you very much for your support.
We would now like to start the keynote lecture. Dr. Shimura, Professor Shimura will be the chair. Please refer to page 30. Over to Professor Shimura.
So we'd like to listen to the keynote lecture by Dr. Dominique Laurier. His biography is written in the program. He currently serves as the Deputy Director of French Nuclear Safety and Radiation Protection Authority. Since the nuclear accident 15 years ago, Dr. Dominique has visited Fukushima many times and provides us a continuous support. Today he will speak on the topic lesson learned from epidemiology on health risk in the field of low doses, sharing the latest research finding on these topics. Dr. Laurier, we look forward to your presentation, please.
Thank you very much, Dr. Shimura, for the kind introduction. And first, I would like to thank the organizers for inviting me, and especially Seiji Yasumura for the invitation. I really think the work which is done here from the Fukushima Health Management Survey is very important for the scientific community, but also for the people to give them objective information about the health status. So I'm really very honored to be here today. So, as has been said, my presentation will be on lessons learned from epidemiology on health risk in the field of low doses. So it's going to be a review of what we know about the effects of radiation and from epidemiology. So we are going to have a short introduction about radiation epidemiology. After that, we are going to speak about cancer, because that's where we have most of the information. A little bit about non-cancer diseases, and conclusions about how to interpret the results from epidemiology. A very classical presentation in the field of ionizing radiation is to consider 2 different categories of effects. Deterministic effects, which are appearing shortly after in people that have been exposed to very high doses. And the treatment is individual, to take into account the individuals and to apply emergency medical treatment. That's not what we are going to deal with here. What we are going to speak about is stochastic effects. Stochastic effects are not specific of radiation exposure, and but the frequency of these effects, for example, cancer, the frequency of these effects is related to the level of exposure. For example, in an exposed group, or group exposed to radiation, we expect that the frequency of these effects will be higher than in a non-exposed group. And so to work on this kind of effects, you have not to work on at the basis of the individual, but to work on the basis of the population. And that's what is doing epidemiology. So that's why epidemiology is very important, to analyze the stochastic effects, especially cancer and non-cancer-like effects of radiation exposure. So radiation exposure is not new. It began in 1950s in the field of radiation, and there are several aims. But what has been accumulated, the knowledge accumulated from epidemiology, is very important to identify the effects induced by radiation, to characterize the time sequence between exposure and effect, and especially what we call the latency, the time between exposure and the occurrence of an excess in the population, to quantify the dose-risk relationship, to model the shape of the dose-risk relationship, and to determine the modifying factors of the relationship, especially variation with age and sex. In the title of my presentation, it's written that we're going to look at low doses. This slide is presenting the definition of what we call low doses in the scientific arena. This is a definition that has been given by the UNSCARE, the United Nations expert group on radiation effects. And what we call low doses is doses that have been received acutely or accumulated over time of less than 100 milligray. To give you a comparison, each of us here is exposed approximately to 2 to 3 millisievert milligray per year due to natural radiation exposure. And to end up with this introduction, the history of epidemiological studies. So the studies began in the 1950s with populations that were exposed due to their work to very high doses, high levels of doses. Radiologists, radium dial painters, medical exposure for non-malignant illnesses. These studies the doses were high enough to demonstrate that there was an increase in the frequency of some of cancer types. But the doses were not precise at all, and so they were not able to demonstrate any dose-risk relationship. The first study that has been able to demonstrate a dose-risk relationship, a relationship between the level of exposure and the increase in the frequency of the disease, is the study of the Hiroshima and Nagasaki bomb survivors. I will come back to this study a little bit later. From the 60s, some studies of occupationally exposed workers, miners, nuclear workers have been launched. And from the 70s, studies of people that were exposed due to environmental sources of exposure, from natural radiation, but also, of course, from the Chernobyl and the last line from the Fukushima accident. And since the last 20 years, some studies also have been launched on especially children with medical diagnostic examinations. So I'm not going to go over all these different studies, but I will focus on 3 of these: the A-bomb survivors, nuclear workers, and children with CT scan examinations. So that was the end of the introduction. And so what do we know about cancer? The first study, the most important study for the radiation protection system is the lifespan study. So the cohort of survivors of the A-bombs in Hiroshima and Nagasaki. That's a very large population, more than 120,000 individuals with reconstruct doses. And this is a low dose studies because 80% of the survivors received doses that were less than 100 milligray. So this study provides a lot of information, even in the low dose range. And this study provided information about what are the cancers that are induced by radiation, what are the estimates of the dose-risk relationship, what is the latency between exposure and increased risk, what is the modifying effect of age. A lot of information have been derived from that study. This graph presents a general relationship. So you have the dose on the x-axis and the excess relative risk on the y-axis. The excess relative risk is the unit which is used by epidemiologists to quantify the risk in a population. It has to be understood as the additional probability of occurrence of a disease, of a cancer, in a group that has been exposed to a given dose compared to a non-exposed group. So if the ratio between an exposed and non-exposed is close to 1, it means that the risk is the same in the exposed and non-exposed group. If this ratio is higher, corresponding to an excess of 20%, for example, then it means that the risk is increased in the group that has been exposed to radiation. So that's what you have on this graph here. The points that are presented here represent the excess relative risk estimated in different categories of dose. And the vertical bars associated with each of the points are indicating the confidence intervals. It reflects the statistical uncertainty associated to the estimate of the relative risk in each of the different groups. So what we can see from this graph is that graphically we can see that there is an increasing level of excess relative risk in the given population, in that population, according to the category of dose that have been received by the survivors. And from these different estimates of excess relative risk in different categories of dose, we can derive what we call a model, a dose risk model. And we can see here that several models can fit the data, but that are very close with something that seems linear with the dose, an increase in the frequency of the cancers associated to the level of dose. And the excess relative risk per gray, so each time we increase the dose by 1 gray, which is a very high dose, then this coefficient is 0.47 on this graph. It means that each time the dose increased by 1 gray, the probability of occurrence of a cancer increased by approximately 47%. That's how it has to be interpreted. But what we are interested in this presentation today is really the risk for low doses. And the low dose range is presented here on this red circle. So the question is, what about when we are in the low dose range? Is this dose risk relationship still pertinent or not? This slide presents you a zoom on the low dose range. So you still have the dose on the x-axis and the excess relative risk on the y-axis. The points are presenting the excess relative risk estimated in different categories of dose. And you can see that it still shows an increase, which is very coherent with a linear model, with a linear extrapolation, which is presented by the black line on this graph. So from the A-bomb survivors, yes, we have the conclusion that even in the low dose range, the dose risk relationship is still there when we consider all solid cancers. That's the first question. When considering all solid cancers, we have a dose risk relationship. But we know that all cancers are not the same. The frequency in a population is not the same. The risk factors are not the same. The treatments are not the same. And so the second question was, do we have also information about the dose risk relationship when we consider the different types of cancer separately? That's what is presented here. On this graph, each point is presenting the slope of the dose risk relationship. And what we can see is that for most of the cancer sites, the slope is a positive one, so showing a positive association between the dose and the risk. The estimates of the slope is more than 0, and 0 would mean that the increase in the risk is flat, no increase with the level of dose. Here we can see a positive association for most of the cancer sites, but for some of them, the confidence interval, the horizontal bar here, is too large to conclude to a significant association on a statistical point of view. But we can see that finally this association between dose and risk is observed not only for all cancer together, but for many different types of cancer. So if we want to summarize what has been learned from the A-bomb survivors cohort, the first one is that the cohort is still ongoing and still providing very interesting results 70 years after the bombings. It has provided information about the radiation-induced risk for many cancer sites, for leukemia, for breast cancer, for lung cancer, thyroid cancer, colon cancer. We have evidence of a dose-risk relationship for all these different cancer sites. The risk of solid cancer and leukemia increases with the dose, and there is a variation with age at exposure. For the same dose, the risk will be higher if the dose is received during childhood than during adulthood. And this is something which is observed for many of the different cancer sites. The latency between exposure and risk varies between a few years to several decades. And the dose-risk relationship is still there when we exclude the survivors with high levels of exposure. The data do not support the existence of a dose threshold, and there is some variation of risk with sex and with age and also with cancer types. So the very interesting results from this population, but this population was exposed over a very short duration. It was acute exposure in a few seconds. One question for the radiation protection system is, what about the risk when the dose is protracted over a very long period, accumulated for several years? And this very interesting population to answer that question is nuclear workers that have been exposed over their whole period of occupation of work. And one major study in that field is the in-work study. It's a combination of 3 cohorts from France, the UK, and the US. The total population is very large, more than 300,000 workers, with a long duration of follow-up, more than 30 years. And this study has been implemented in order to analyze the risk between a dose which is cumulated over time and the risk of cancer and other diseases. So this slide presents the results. That's the same presentation as for the A-bomb survivors. So on the y-axis, you have the relative risk according to the cumulated exposure and the x-axis. And again, you can see that the estimates of relative risk are increasing according to the cumulated dose. The results show a dose-risk relationship, which is presented by the linear model here, with a coefficient which is very close to what was estimated from the A-bomb survivors, 0.52, so an increase of 52% in the risk of cancer each time the dose is increased by 1 gray. The relationship is still there when only the workers with low doses are considered, and there is some indication about a curvature, but a significant dose-risk association here with people that are exposed chronically over time. This graph presents the same results for leukemia, which is a specific type of cancer related to bone marrow cells. And again, the coefficient is, as expected, much higher than with the solid cancer, but well described by a linear model with no indication of a threshold. So all these results are very difficult to interpret, those risk relationship, the confidence intervals, and so on. To help interpreting these results, we can use what we call the attributable risk. This is using the results from epidemiology to calculate the number of cases that we can attribute to a given level of exposure. If we consider 1,000 workers with the same characteristics as the workers in in-works, then with the same duration of follow-up, we expect 334 deaths, just because these workers are aging over time. And from these deaths, approximately 93 will be from solid cancer and leukemia. And among these deaths, approximately 1 is attributed to ionizing radiation exposure. So it means that, said otherwise, if this population was not exposed to radiation, 1 death by cancer would not be there. That's the level of exposure, 1 case in 1,000 workers. So that's a very small risk. And that's the reason why we need so large epidemiological studies to demonstrate very low increase in the frequency of cancer in an exposed population. If we want to compare the results with other studies, so this graph presents the slope of the dose-risk relationship estimated from different cohorts. INWORKS is the fourth column, and the A-bomb survivors is the last columns. The three first columns are the three cohorts that are included in the INWORKS study, so the French, the UK, and the US. You can see that there are some variation between different studies, but globally, all these different studies are providing a slope which is a positive association with more or less statistical uncertainty associated to that, but some coherence between the results obtained from different studies, and very similar to what has been estimated from the A-bomb survivors. This is the same graph for leukemia. The level of risk is higher, but again, you have a rather good coherence between the different estimates from the different population. And again, if you compare the coefficient of risk estimated from INWORKS and from the A-bomb survivors, you can see that the two estimates are very close. So the results that are very similar, but in one population that's an acute exposure, and the second one that's an exposure that has been protected over several years or decades. So that's what we can conclude from the workers. As I told you at the beginning, one lessons learned from the A-bomb survivors is that for the same dose, an exposure during childhood may lead to a much higher risk than the dose received by an adult. To check that, several studies have been launched in the recent years on children who undergone some CT scans during childhood. So that's a very interesting medical exams that are applied for diagnostic purposes. And the question was, are these doses, due to medical exams, associated with a risk of cancer in the years or decades after the exam during childhood? So a very large cohort has been launched, international project had been launched in Europe, including close to 1 million children in this population, so a huge study with a very precise reconstruction of the doses due to the scans and collection of information and similar protocol in the different countries. Again, very rapidly, the results are presented here. So more than 876,000 individuals were included in that, with a median follow-up of approximately 8 years. The doses were really in the low dose range. The mean dose was approximately 15 milligrams. And the estimated excess relative risk is presented here, 1.86 per 100 milligrams for leukemia, for malignancies, hematological malignancies, and with a slope which is presented on the graph, and significant association. As for the INWORKS, you can calculate, to help interpretation, you can calculate the attributable risk from that population. And the risk per 10,000 people undergoing a CT scan is expected to be approximately 1.4 radiation-induced case. So approximately one additional case in 10,000 people undergoing a CT scan. That's the magnitude, an estimate of the magnitude of the estimated risk. A second study, even larger, has been published last year, still on childhood CT scans, including more than 3.7 million children from Canada and the US. The follow-up was 10 years after the first scan, and the accumulated dose to red bone marrow was 14 milligrams, so we are still in the low dose range. And the estimated dose-risk relationship is presented here, showing a significant association also with a coefficient which is 2.5 per 100 milligrams. The previous one was 1.9. So again, very coherent results from two different studies on the same population with different protocols, but very similar results. So to conclude this review of what we know about cancer, I'm not going to list all the different results, but we have several very big studies that have been published, studies or meta-analyses that have been published in the last years. In works, I told you about that, more than 300,000 workers. A meta-analysis on low-dose rate studies, more than 20, including 22 different studies, more than 900,000 individuals. A study on a meta-analysis, a pooled analysis on thyroid cancer, including more than 100,000 individuals. On leukemia, a pooled analysis also on more than 262,000 individuals. The EPCT study and the RIG study, I just presented it before. So all of these different studies are very big studies with very large population and able to demonstrate very low risk associated to radiation exposure. And the characteristics of all these different studies here is that they provide significant association when doses above 100 milligray are excluded. So only considering doses below 100 milligray, we have a significant association for all solid cancer or for leukemia or thyroid cancer. All these results are rather new and really obtained in the last decades. But it's very complementary to what was already known from the A-bomb survivors. So to conclude about the risk of cancer, there is clearly a clear improvement in knowledge in the last 2 decades, thanks to additional studies, new populations that have been included in epidemiological studies. There is some evidence of some excess risk of some cancer following low-level exposure to radiation. So, of course, not all epidemiological studies are showing a dose-risk relationship. But if we look at the largest one and the most important ones, we have a significant association. Some evidence of an increased risk also with repeated or protected doses. No indication of a dose threshold, and the deviation from a linear model is not persuasive. And the last line is maybe the most important one. We have better knowledge of risk even in the low dose range today. But what we know really is that when doses are low, the risks are low. When we are dealing with very low doses, the excess risks are very low. That's the gain in knowledge that we had in the last decades. So let's move very rapidly on non-cancer disease. Now, in the recent years, there have been a lot of new results also on long-term chronic disease like cardiovascular disease or cataracts or mental neurodegenerative diseases. On cardiovascular disease, it's well known that a risk can be associated with very high doses after radiation therapy, for example, since the 80s. But in the recent years, there have been a lot of publications, approximately 100, showing an association with the level of radiation in very different populations, even in the low dose range, below low to medium dose range. So let's say with a few hundreds of milligray. And so this is questioning the system. Is cardiovascular disease a disease which is related only with high dose exposure, or is it also existing when we are dealing with levels of doses that are several tens to hundreds of milligray? And this question is still ongoing, but there is some results in the last years showing and suggesting a dose-risk relationship. On cataracts, on lens opacities, again, that's something which is not new. It's well known since a very long time that very high doses can lead to an opacity of the lens of the eye. But recent results in the last years, in the last decades, show also a significant association at levels of dose that are of several tens of hundreds of milligray to the eye. And so challenging again the system, which is considering that there is a threshold at 0.5 gray. For neurocognitive disease, also a lot of results have been published in the last decades, several tens of studies, suggesting a positive association with dementia or Parkinson's disease. This is very premature. That's very, very recent results, and we have to be very careful with the interpretation of these results due to very diverse endpoints, very different methodological studies. So at the time being, we are very cautious, but maybe that's something that has to be considered as a positive dose-risk relationship in the future. We have been discussing in the previous session, there have been some results on the results for not for the people themselves, but for their children. We call it the hereditary effects. Hereditary means that the hypothesis is that there could be an increase of in some pathologies in the children of parents that have been exposed before the conception. So something like a transgenerational transfer. And such a mechanism has been observed several decades ago from animal experiments, from flies, from rodents, at very high levels of doses, above 1 gray. A review of the literature from epidemiology, so on humans, on population that have been exposed, parents exposed before the conception, and looking at potential effects in the children. More than 130 epidemiological studies have been revised in the frame of ICRP task group. And the conclusion is there is no association. First, we have to be very careful with this interpretation because the data are very heterogeneous with a lot of limitations in most of the studies that have been published. But there's no evidence, no coherent evidence of an effect in the offspring of humans that have been exposed to radiation before the conception. And if there is something, clearly it has to be small and very difficult to reproduce in a human population. So the conclusion is clearly today no evidence for an association between the exposure of the parents and the risk for the future generations. And to finish with non-cancer disease, but that's most of the knowledge that we have today is coming from the Fukushima Health Management Survey. It's that epidemiological lessons from the Chernobyl and Fukushima accidents that there are some consequences not related to the dose that has been received, not radiation induced, but consequences of evacuation and increase in the frequency of metabolic disorders in people that have been evacuees and for which there has been a huge change in the way of life. Deterioration of mental health, all these different results are also very important if we want to look at the global picture of the potential effects of a nuclear accident. So to conclude on non-cancer effects, what we can say is that there is an increasing number of epidemiological results on long-term non-cancer effects, increasing frequency of lens opacities, of disease of the circulatory system, also for neurocognitive effects, even if I think we have to be very prudent with this one. But we have to consider that there is a very large heterogeneity of results, and clearly we are not at all at the same level of knowledge that we have for cancer regarding a positive potential association with radiation. And several international groups of experts are working on these topics at the time being. So I would like now to move to the conclusion. The first one is we have to be very careful when we interpret results from epidemiology. Epidemiological studies are only observation of a population over time. And that's difficult to design, to conduct, to interpret. And we know that there are limits, that there are other factors outside of radiation that can play a role on the different endpoints that we are looking at, cancer, cardiovascular disease. We still have a lack of knowledge, even if there is some new knowledge over the last 20 years, we still have a huge lack of knowledge for very low doses. So we have to be very careful, and when we are looking at one result from epidemiology, we have to consider all the available data and to perform a synthesis of all available results. But if we look at this very graphically, this graph, where we were 20 years ago, we had some results above 1 milligray, so in the medium range. From that, it was possible to estimate a dose-risk relationship, and we were extrapolating from high doses or moderate doses to low doses using a linear model, but with a strong uncertainty in the low dose range. In the last 20 years, clearly we have know a lot of additional information, even below 100 milligray. And today, for cancer, we are no more obliged to extrapolate from high doses to low doses. We have some observations, even below 100 milligray. Even if we still have uncertainty area, we have some results showing that this projection of risk is completely coherent with the available data that we have today. It's very important for the radiation protection system. These results are providing new results on the shape of the dose-risk relationship for acute exposure, for protracted exposure over time, about the modifying effects of the dose-risk relationship, about the effect of age, about the risk among children, about difference between population when we want to transfer the risk from one population to another one. The new results are coming from all over the world, so we are not dealing with only one population from Japan. And about new knowledge about non-cancer effects also. And these results are clearly considered at the time being in the radiation protection system, especially in ICRP Committee 1. We have 10 different task groups ongoing at the time being, and clearly these results, the new results from epidemiology, are really considered in these different task groups to be considered in the new recommendations in the future. And the process is ongoing. It has been launched in 2020 by the ICRP, the International Commission on Radiological Protection. And the process is ongoing, and the idea is that these results from epidemiology will contribute to the production of new general recommendations in, let's say, 5 years from now. But beyond the radiation protection system, I would like to say that these results from epidemiology are also very important, as it has been said in the first session at the beginning of the afternoon, for the preparedness of post-accidental epidemiological surveillance. A European project was ongoing, the Shamisen project, and FMU was strongly involved in this project. And the lessons learned from what has been done, the protocol, what have been the problems in the implementation and the follow-up of the Fukushima Health Management Survey are very important for the different countries who would like to prepare for in case of a nuclear accident. And that's the case in France, where I'm working. We have been asked by the health authorities very recently to think about how to prepare ourselves for, in case of an accident in France, to launch an epidemiological surveillance. And clearly the answer is really taking into account the lessons learned from the Fukushima Health Management Survey, considering not only radiation-induced risk, but also risks that are linked to the accident and to the evacuation and to the relocation of the population. And so there are a lot of information that can be derived beyond or maybe in the system of radiological protection from the experience of the Fukushima Health Management Survey. And with this last slide, I would like to thank you very much for your attention.
thank you for your wonderful lecture. Can we have right? In this lecture, he introduced recent studies with a large number of subjects or meta-analysis have revealed the previously unknown health risk of low-dose radiation exposure. And he also introduced new findings on effect of radiation exposure other than cancer, but such as cardiovascular disease and neurocognitive functions. We have many questions for your lecture. I would like to ask us a few questions. First question is you presented the effect of low-dose radiation risk. However, in Fukushima Prefecture, the highest thyroid dose was approximately up to 30 milligray, and the majority of people were exposed to radiation in a very low dose range, less than 10 milligray. How should we think about the risk of thyroid cancer in Fukushima Prefecture?
Yes, thank you. That's a very pertinent question. From what I show here, what we have to keep to keep from my presentation is that we have today more data to demonstrate those risk relationship even at level of doses that are of a few tens of few hundreds milligray. It does not mean that the risk is higher than what was expected before, but we have a better opportunity to quantify and to demonstrate this risk and to have a better, more precise estimate of the risk. After that, when we are dealing with very low doses, it's clear that the estimates are very uncertain, and as I said before, the knowledge that we have today is that there is a dose-risk relationship, but when we are dealing with very low doses, the excess probability of occurrence of a cancer in a given population is very low, depending on the level of dose. The situation in Fukushima is that for most of the people, the doses are very low, and so the increase in the frequency of population it's not possible to demonstrate it by an epidemiological study. What I just presented before is that we have a gain of knowledge in the last decades, thanks to very, very large studies. The studies were several hundreds of people, several millions of children. It's not because the risks are very high, it's because the risks are very low that we need such a very large population. So to come back to the Fukushima population, the doses are so low that if there is an increase in risk, it's so low that there is no chance that it will be demonstrated by an epidemiological study. And for some people that receive doses that are a little bit higher, the number of people is so small. Then again, the statistical power, clearly an epidemiological study should not demonstrate anything.
Okay, thank you. So, can you share your opinion about the other cancer, other non-thyroid cancer in Fukushima, the risk of non-thyroid cancer in Fukushima?
Well, thyroid cancer and leukemia among children are the two cancers for which those relationships are the strongest ones, with a short latency between exposure and the occurrence of an excess risk. So if we can see something, if something has to be expected in a given population, that's the two indicators of something. So maybe to look at other cancers would be interesting for childhood leukemia, and for other cancers, maybe that could be of interest, not as an epidemiological study, but just to provide information about what is the frequency of cancer in the population, just as a surveillance, to provide information which is as objective as possible, not only for thyroid cancer, but for the other cancers.
Okay. Actually, we performed a health checkup survey to abnormality in the blood cells, and we had a cancer registry system.
I think that's the good idea. Now you have a cancer register, and so of course it's possible to use the two sources of information. So the data from the basic study about the distribution of the doses and the cancer register, and to bring the two sources together. That's something that of course can be done. So
thank you. And next question is regarding dose risk relationship in the effect of cardiovascular disease and neurocognitive function. What do you think about whether it is related to biological direct radiation effect or secondary change in the environmental issue or something like that? It's a difficult question, but
again, I would like everybody to be very careful about the results on non-cancer diseases. We are not at all at the same level of knowledge than what we have for cancer. But there are emerging results, especially during the last 20 years, that are showing a potential association. For this, we have almost no information about what could be the mechanism, the biological mechanisms between radiation exposure and the endpoints. So there is still a huge need for research. But in my view, we have to consider for cardiovascular disease, for example, we have to consider radiation as one additional risk factor, and not only that cardiovascular disease is created by radiation, but that radiation is one additional factor to what we know already: smoking, diet, physical exercise, body mass index, cholesterol. We have a lot of knowledge about the risk factors. Maybe radiation is one additional one, not the strongest one, clearly, but we have to consider it as one additional factor. So if there is an excess in a given population, I really think that the change in the way of life, which is responsible for that, and not radiation exposure at very low doses.
So time has come, but final question. Could you please share your expectation for our activity in Fukushima?
But the continuation, my expectation is that the Fukushima Health Management Survey can provide as objective as possible information on the health status of the population that has been impacted by the accidents, for people that have been evacuated, for people that are still residing that exposed to very low level of doses, and so to participate to this analysis and to look at the distribution of the cases and doses, maybe using the data from the register can be very helpful. And the second topic, that's what I presented here. We have been asked by the health authorities in France to prepare what, in case of a nuclear accident, how and what should be implemented as a kind of epidemiological surveillance to assess the potential risk. And clearly, the lessons learned from the Fukushima Health Management Survey are very important for that. Dr. Yasumura has been participating to this group in France, and I really think we have to use the lessons learned from that to build up the preparedness for epidemiological studies in France, but also more largely in Europe and in many different countries.
Okay, time has come. Thank you very much. I really appreciate your kindness for Fukushima.
Thank you very much.
Since it is time, I would like to start. this session for the future in disaster affected areas. And Masaharu Maeda is the moderator and chair. And Tsubokura-san, Professor Tsubokura and Professor Maeda, please. I would like to go on to session 2, the future of the disaster-affected area, building the brighter tomorrow. I would like to ask the Professor Kamiya as a first presenter. As you know, he is the head of the center of the RERF. And thank you very much for your introduction. My name is Kenji Kamiya, Radiation Effects Research Foundation. And up until 2023, I was involved in the prefecture health management survey at the Fukushima Medical University. And this is after the atomic bomb 80th anniversary. This is I feel very fortunate to have this opportunity to talk in front of you. And I'd like to extend my gratitude to the sponsor. And also our company, RERF, is for long term doing the survey on the impact of the radiation, and we have learned a lot through the Hibakusha that radiation affected people, and how it has had the great impact on the human being is a topic I'd like to cover today. So let me begin with the atomic bombing. In 1945, August 6, at the Hiroshima, and next on 9th of August at Nagasaki, the atomic bomb was dropped. So as you can see here, the Hiroshima TNT level 16 kilo, and the Nagasaki and 21 kiloton are the equivalent. And 1945. By the end of 1945, the estimated death is the Hiroshima, 140,000, and this is about 38% of the population. And also Nagasaki, 74,000 people, and that is roughly 28% of the population at Nagasaki. At the same time, a large number of survivors were created. The long-term health effect on atomic bomb radiation on survivors have been studied by the Radiation Effect Research Foundation, a joint Japan-US Research Institute. We have laboratories in Hiroshima and Nagasaki. Today, based on the findings from these studies, I would like to share what we have learned from the survivors. Let me briefly introduce the history of RERF. Then the predecessor, ABCC, Atomic Bomb Casualty Commission, in 1947, the National Academy of the United States funded for this establishment. 1 year later, and Japan's National Institute of Health participated in the survey 1 year later. In 1975, based on that agreement between the government of Japan and the United States, ABCC was reorganized into the Radiation Effect Research Foundation as a legal entity under Japanese law, and ABCC's research was carried on. And at that time, we had equal partnership between Japan and US. So the operational cost was split between Japan and the United States. And this slide shows you the pattern of the leukemia, solid cancers, and non-cancer disease observed for a long time. And solid cancers and other disease standard cancers. And the solid cancer means is like the type of cancer which makes the lumps, such as stomach cancer and breast cancer. And the red one, the leukemia, began to appear about 2 years after the exposure and peaked around 7 to 8 years and then declined. And in contrast, solid cancers develop more slowly and starting about 10 years after the exposure and gradually increasing over time. And for non-cancer diseases, other than the acute effects, there are some conditions we found to increase later in life. And this shows you the physical effect overview on the survivors. And among survivors, as I showed earlier, the leukemia and various solid cancers have been observed. In addition to cancer, there are non-cancer diseases such as cataract and thyroid disorders. And for the internal exposure, that the intellectual disability and growth impairment was observed, and also that in women there were increase of the solid cancer, and also genetic impact for cancer and other disease, that lifestyle-related disease have been surveyed, but there was no distinctive increase of those diseases. And the systemic evidence is shown here. And this is epidemiological and clinical studies conducted by RERF. And this is the large-size cohort. And for long term, we are doing the follow-up, and so that we can find out what type of disease increases. And this shows you the overview. And the core part of these studies are these three studies. The first one is started in 1950 for about 120,000 participants and lifespan study. A second one is 3,600 individuals. It's internal exposure study. And third one is started in 1946. Covering 77,000 children and survivors. In addition to these epidemiological cohorts, that the clinical sub-studies have been conducted within each program. And also, another important element of epidemiological research is accurate dose estimation. This figure shows the estimated radiation doses of for survivors and done by RERF. And this system measured Nagasaki and Hiroshima's survivors' radiation doses by different colors. And looking at these figures around the hypocenters, you see the bands of different colors. And these colors means the group of dots, detailed dots. And dots indicate the location. And also estimated radiation dose. And blue color, 5 to 100 millisieverts. And due to the radiation, when there's cancer, then as dose increases, the risk of cancer increases. This figure shows you that. And horizontally, you see, as you go right, it is getting bigger. That is the radiation dose. And the vertical axis shows the cancer risk. And if it is a 2, and compared to the non-affected, non-exposed group, that the risk is twice as high, twice as high, and that is this inclination is rather linear. And using this relationship, then actual exposure dose and risk can be estimated if 1 gray is used. and the relatively risk is about 1.5. It means, and based on this approach, in case of Fukushima accident, if we find out the residents understand that the radiation doses are received by evidence, then we can estimate the overall health impact on that affected population. And for the if the exposure is less than 100 millisievert, then there is a much variation. So risk is not easily found as increasing. And this slide shows you which type of cancer was increased among atomic bomb survivors. And this is the result of the lifespan study up to 2009. And vertical axis lists the organs where cancers occur. And the horizontal axis shows that cancer risk per 1 gray expressed as relative risk. The dashed line represents the relative risk of 1, which indicates no increase in risk. If you go right, then the cancer risk is increased significantly. And looking at the esophagus and stomach and colon cancer are going right significantly. And the other cancers are significantly increasing. And this is the summary. And you can see many types of cancers have increased among the survivors. Then, in these studies of atomic bomb survivors have revealed several other important observations about the effect. The age at the time of exposure is shown, and vertical axis represent the risk of cancer, and the horizontal axis shows the age at the time of exposure. And at the age of 5, 15, and 25 years old, you can see that the risk is highest for those exposed at age of 5, and it decreases as the age increases. So the higher the cancer risk among those exposed at the younger ages have been observed. And on the other hand, there are other cancers, and typical one is breast cancer and also the uterine corpse cancer. Horizontal axis shows the age of exposure, and the vertical axis shows the cancer risk. For the breast cancer, the risk at the time of menarche is highest. And as that age is early, then the risk is higher. So in case of a uterine corpse cancer, this shows you the mean age, and exposure just before that is the highest risk. So the findings from studies of atomic bomb survivors have been highly recognized by international organizations. And in order to set the standard for global radiation protection, it has a great role. And let me talk about the overview. And data from RERF and the UNSCARE is scientifically evaluated, and this UN SCARE is the United Nations body. Assessment of radiation risk is considered highly authoritative, and it is seen as a standard internationally. ICRP, International Commission on Radiological Protection, based on the UNSCARE, regarding the protection, they set that the various standards. Based on these standards, IAEA developed the practical radiation protection guidelines and the safety standard. And this is the safety standard countries are using as a basis of their regulations and laws. So within this system, the data obtained through the cooperation of atomic bomb survivors form one of the most important scientific foundations for global radiation protection. And many of you may not be very familiar with the radiation protection, but radiation is actually used in many areas of our daily lives. This slide shows you some of the fields where radiation is used. In agriculture, for example, it is used to prevent potatoes from sprouting, and in medicine, as you know, it is used for diagnosis and the treatment of the cancer. And radiation is also used in university research institute and the industry for non-destructive testing in nuclear power plants, as you know. And the radiation can be used safely in these fields because radiation protection standards, like the ones I mentioned earlier, are carefully followed in each workplace, ensuring the safety of the workers. And this slide summarizes nearly 80 years of research achievement and their contributions. Through large-scale cohort epidemiological studies of survivors and their offsprings, RARF has elucidated the long-term health effect on atomic bomb radiation. So these findings from the Scientific Foundation for Support Program for Survivors and are used in health management, diagnosis, and prevention. At the same time, as finding constitutes a core scientific evidence base for international radiation protection framework developed by organizations such as UN SCARE, ICRP, and IAEA. And also these findings provide the crucial evidence base for promoting accurate understanding of radiation effects worldwide and risk communication in events such as the Fukushima accident. So this major achievement would not have been possible without the cooperation of the atomic bomb survivors and their children. For this reason, RARF has always conducted its research with a deeper gratitude to the survivors and their children, and with trust as the foundation of our work. So this slide shows you commemorative publications, plaques, and appreciation, and certificate of thanks that RARF has prepared at key milestones in history to express their gratitude. So the question we are now facing is this: how are the findings from the survivors and their offspring studies shared with people nationally and internationally? That's my understanding. In 2011, the Fukushima nuclear accident occurred, and large amount of radioactive material was released into the environment.
This slide shows examples of local media coverage immediately after the accident. If we recall now, a large amount of misinformation about radiation health effects spread through the internet and the media, causing serious reputational damage and distress for people in Fukushima. At the same time, many parents were deeply concerned about their children's health and experienced strong anxiety. As commented in Fukushima Prefecture, the Fukushima Health Management Survey was launched to monitor the health of residents, and it's been shared. The findings has been shared every year at this symposium. The survey includes these various types of survey and examination, and as reported by Director Yasumura and colleagues, to date, no findings have been identified that directly indicate health effects attributable to radiation exposure. This slide summarizes previous slides. Estimates of external effect radiation doses during the first 4 months. Specifically, 99.8% of residents received external doses below 5 millisievert. An independent oversight committee established by the prefecture examined the potential health effects of these exposure levels and concluded that they are not at a level at which statistically significant health effects can be confirmed. This slide shows trends in the cumulative number of disaster-related deaths and disaster-related suicide in the 3-month affected prefecture, Fukushima, Miyagi, and Iwate. Underneath, so the top half shows the change in the number of disaster-related deaths, and underneath is change in the number of suicides, disaster-related suicide. And among these prefectures, Fukushima has the highest cumulative numbers of both disaster-related deaths and suicides. One possible factor is the presence of nuclear accident. As mentioned earlier, the Fukushima Health Management Survey has not identified findings that directly indicate health effects caused by radiation exposure. Therefore, the nuclear accident should be understood not only as an issue of physical health effects from radiation, but also as an event that had profound impacts on people's mental health, psychology, social system, communities, and human relationships. In this context, an important question becomes how people perceive and understand the health effects of radiation. We would now like to examine how people perceive radiation-related health effects using perception of genetic effects as an illustrative example. This slide provides an overview of genetic effects research conducted by ABCC RERF to date. At ABCC RERF, studies began with investigation on congenital abnormalities at birth and later expanded to include chromosome analysis, mutations in blood proteins, and DNA studies in 1985. In addition, epidemiological and clinical studies have examined outcomes such as cancer incidence, mortality, and prevalence of lifestyle-related diseases. However, so far, no evidence of genetic effects has been identified across these research areas. Next, I would like to show the results of epidemiological and clinical studies. This slide presents findings on cancer mortality among the offspring of atomic bomb survival. The left figure shows the results when the father was exposed, and the figure on the right shows the results when the mother was exposed. The horizontal axis represents the radiation dose, and the vertical axis shows the risk of cancer mortality. As you can see, even parental radiation dose increases, there is no increase in cancer mortality risk among the offspring. This slide shows the results of prevalence of lifestyle-related disease among the offspring of atomic bomb survivors. The pale color indicates whether the father was exposed, the mother was exposed, or both parents were exposed. So we analyze the conditions like hypertension, hypercholesterolemia, and diabetes, and no significant increase has been observed. This slide shows the results of a question from the Fukushima Health Management Survey asking whether people believe the Fukushima accident could cause transgenerational or genetic effects. In fiscal year 2011, shortly after the accident, about 60% of respondents answered that genetic effects are likely or very likely. However, as scientific knowledge about genetic effects was gradually shared, the percentage steadily declined, and by fiscal 2023, about 20% of respondents still believe that genetic effects might occur after the Fukushima accident. Immediately after the Fukushima accident, RERF's scientific data had not been shared with people in Fukushima or the broader population. As a result, not only misunderstanding about physical health effects, but also many misconceptions about genetic effects spread, leading to stigma and discrimination. Despite the relatively low radiation doses, more than 60% of residents initially believed that genetic effects would occur. One newspaper story describing a junior high school student in Fukushima crying to her mother, saying she might not be able to conceive, deeply shocked all of us. To address this situation, the Ministry of Environment launched Guguru Project, whose slogan is "Toward a society free from misunderstanding, rumors, prejudice, and discrimination related to radiation health effects." This slide shows the results of nationwide survey conducted by Guguru Project on perception of genetic effects. Around 2020, nearly 40% of people across Japan believe that Fukushima accident could cause genetic effects. Since the launch of Guguru Project, various initiatives have been implemented to promote knowledge dissemination, improve public understanding. However, over the 5 years from 2020 to 2024, public understanding has not significantly improved. This data illustrates how challenging it is to communicate accurate scientific knowledge about radiation health effects to the society. Looking back at the earlier data from the 3 disaster-affected prefectures, Fukushima has the highest cumulative numbers of disaster-related deaths and suicides. This may suggest that insufficient sharing of scientific knowledge about radiation health effects could be associated with broader social and psychological implications. What we have learned from atomic bomb survivors. Last but not least, in 2016, President Obama became the first sitting U.S. president to visit Hiroshima. He delivered a message calling for the pursuit of a world without nuclear weapons and met with atomic bomb survivors. One of the survivors he met was Mr. Sunao Tsuboi, who was then the chair of Hiroshima Prefectural Hidankyo. In 2023, under Prime Minister Kishida, the G7 summit was held in Hiroshima, and they paid tribute to the victims by laying flowers in memory of atomic bomb survivors. There is a recorded message from Mr. Sunao Tsuboi given at the 30th anniversary ceremony of RERF, and let me share them with you. For atomic bomb survivors, it was not easy to cooperate with ABCC, a research organization established by the United States. With that historical background in mind, let me share Mr. Tsuboi's world. Although the original message is quite long, I will only read the underlined part. However, we must overcome many challenges as we move toward the future. As survivors, we sincerely wish for the abolition of nuclear weapons for the sake of humanity's future, and we are determined to fully support research on the effects of radiation. At this 30th anniversary ceremony, Mr. Tsuboi kindly took part in tree planting ceremony for second-generation aogiri tree that survived the atomic bombing. The aogiri, a Chinese parasol tree, which lived through the bombing and sprouted new leaves, have become a powerful symbol of rebirth and recovery in Hiroshima. When it was planted, it was a very small sapling, but after 20 years, last year, RERF commemorated the 30th anniversary, and it's been 20 years since the sapling was planted, and now we see a vibrant, flourishing tree. And then in 2024, Nihon Hidankyo was awarded the Nobel Peace Prize. Mr. Mimaki, the successor after Mr. Tsuboi, he made a comment at the reception, and we were deeply moved by the emotional moment. we believe that we learned two profound messages from the Hibakusha and have inherited their legacy. The first is the call for the abolition of nuclear weapons, and the second is to resolve to never create new Hibakusha again. Guided by these messages, the Hibakusha shared their own experiences and led actions toward the realization of a peaceful world free of nuclear weapons. Their voices resonated globally, inspiring deep empathy and ultimately leading to the award of the Nobel Peace Prize. I believe the second message, never create new Hibakusha, carries another important legacy. It is the decision to entrust the understanding of their own health effects to science and to cooperate in research. The knowledge gained through this cooperation has formed the foundation of radiation protection, safeguarding people from radiation-related harm, and has now become a legacy for all humankind. We will continue to honor the messages and legacy of the Hibakusha A-bomb survivors, to apply the experience and knowledge of Hiroshima and Nagasaki to support recovery in Fukushima and to fulfill the responsibility that the affected region must carry for the future. Thank you for your attention.
Thank you very much, Dr. Kamiya. Hiroshima and Fukushima, you are doing many important work in those places, and the presentation was very impactful. As for questions, we are going to entertain those questions in the discussion session later. And we're going to close the presentation by Dr. Kamiya. And we would like to move on to the second presentation of session 2. This is from Hyogo Institute for Traumatic Stress. Dr. Kato is going to present. Dr. Kato is well known in this area, and especially mental health care during the disaster, and kokoro no care has been also devised by this doctor. And doctor also went to Hyogo, and then after coming to FMU myself, I received many visits of Dr. Kato, and I have been encouraged greatly by Dr. Kato, and we are going to hear from Dr. Kato. Thank you very much for your introduction. And in the first symposium, I remember being invited, and I'm very happy to be invited once again. And in the 15 years, the support to the people who have been affected by the disaster, I am very much impressed by this. And today, I'm not going to discuss radiation, and rather what kind of mental health care or post-disaster mental health care has evolved, and that is going to be my topic today. And post-disaster psychiatric medical care, and this is very closely related to the disaster relief activities as well as mental health activities. So it comes in different phases. The first phase is acute phase right after the disaster. And what is important is that the psychiatric hospitals could be impacted by the disaster, and so how we take care of such damage is the first thing we have to think about. And then we have to think about the community health activities and how we are going to support the supporters of the disaster. And then in the recovery phase, there will be residents of temporary housings, and we need support to those, and also, so to speak, high-risk residents, and as well as educational activities will be required. If we look at this in three phases, it will be easier to understand. And first, I would like to discuss the early phase psychiatric medical care, and especially when the healthcare institutions are impacted, the objective is to provide support to that. And in Japan, so there are the psychiatric medicine here in Japan are mostly run by private institutions, and therefore support to these institutions will be important. And especially in the metropolitan areas, that is where the patients would go. So how to support people living in the non-metropolitan areas who have been going to hospitals and clinics in the metropolitan area is another issue. And then also newly emerging psychological problems will also require attention. And so how to address these issues have been tested in the past disasters. And in the Hanshin Awaji earthquake, so this happened in the metropolitan area, and therefore we had to provide support to disaster-affected psychiatric clinics. And also new problems emerged. For example, many institutions have been affected, and therefore the support to these have been a big issue there. And in the Hanshin Awaji earthquake, before that earthquake, the mental care have not been assumed that of such requirements. However, when many mental care institutions have been affected, for example, schizophrenia and other mental conditions, lost the provider of the care. And so how to provide care to those patients have been an important issue. And there they came up with this psychiatric disaster relief base have been established, but there were many issues there. For example, there was nobody to provide coordination, and therefore people came from around the nation, and people were doing what they thought they needed to do, and this led to confusion. And also, based on those learnings, this mental care, which we called kokoro no care, we recognize the need to establish a structure. And with that, 15 years ago, during the Great East Japan earthquake, so there were new issues that were not experienced in the previous earthquakes. That is the psychiatric hospital directly being damaged. So in the three major hospitals, we needed to transfer 300 patients, and then also in Fukushima from Hamadori, we needed to transfer patients in a rush to the other hospitals. The issue in Miyagi, we only found out about the damage after 1 week because of tsunami. We did not get information about the damage. And in Fukushima, from 5 hospitals in Hamadori, we have to transfer the patients in bus. And as you know, in case of dementia patients, it is difficult for them to be seated, and therefore it is ideal to have them in stretchers, but we had to have them seated, and due to that fact, unfortunately, 20 patients have passed due to this fact, and we did receive criticisms for that, and it became a social issue. And the support team came from around the nation, and there are regional differences. And for example, in Miyagi, Sendai and Ishinomaki, which had the best access, there were many support teams. But in Ishinomaki, Kesennuma, and other non-accessible regions, not many teams got to go, and Fukushima was even worse. Hamadori received 0, and there were only 2 teams going to Aizu, and therefore there were regional discrepancies, and many insufficiencies occurred during that time, as well as confusion. And we needed to learn from that and change the situation, and many considerations have been done, and that led to the establishment of DPAT. And this is modeled on DMAT, which was established after the Hanshin Awaji earthquake. And one of the objectives was to provide proper support to psychiatric hospitals, and the system structure of information and command and control systems have been established. And this DPAT was very active in one disaster, which was Kumamoto earthquake. Compared to the East Japan earthquake, and the west of Japan has many psychiatric hospitals, and therefore we needed to transfer 591 patients from 7 hospitals, and DPAD played an important role in this, and we felt rewarded to have established DPAD. And as I have mentioned earlier, the Japanese psychiatric healthcare provision is reliant on the private institutions, and therefore this was a very meaningful endeavor. And it's also, up until that point, the psychiatric activities was out of the scope of regular disaster relief activities. But thanks to the experience in Kumamoto, now that the DPAD's role has been recognized more, and so we became a part of the disaster relief headquarters. Having said that, a system like DPAD will require the coordination, and because many teams will come to those disaster-affected areas. And in Makisi City, as you can see in the photo, many teams came, and the relief team members were flowing out of the room. And there were public health nurses, only 3 of them, and those 3 of them had to address this chaotic situation, and they had many challenges there. And on the other hand, the adjacent town, which is called Kashimamachi, the disaster level was approximately the same, but there were almost no relief team coming to that town, and therefore coordination and information management require more measures. And this is what we learned from this disaster. And by the way, and this is the photo from the Noto Peninsula earthquake, and this is the headquarters of DPAD. And in Noto, due to snow and road damages, not many teams got to reach this area. So most of the teams had to wait in Kanazawa town, in the center of the town, and therefore this showed an aspect that was not so efficient. And this shows our acute phase activities.
その課題というのをここで列挙しておりますけれども、言うまでもなく精神科病院の
DPAD challenges are shown here, and this shows the activities in psychiatric hospitals. And so when in the big cities, what the kind of activities DPAD does, we need to have a deeper discussion. And also there is an unevenness of the response, and therefore some burden on receiving institutions as well. And another issue is that with DMAT, the activity lasts for only about 1 week, and therefore we have to determine when to end this activity. So these are the things that we need to consider going forward as well.
Now, I'd like to talk about the midterm, long-term, activities. It is a mental health care center, psychiatric medical care center, and looking at the hierarchy, the regional. There are some disasters which can be resolved on a regional basis, or sometimes we need to have an increase of number of resources depending on the type of disaster, such as water-related disaster, typhoon, and flooding, and so on. And other than what the type of things are necessary, then we need to have a dedicated organization for mental health care centers. And after the Hanshin Awaji earthquake, in some places, this has been the initiative. So let me talk about what type of center these Kokoro no care centers. So, and these Chuetsu, it's not that the size of the disaster was not so big, but considering that the annual budget And the East Japan Great Earthquake, 2.7 billion yen, and Eastern Great Earthquake, Miyagi, Iwate, and Fukushima, and they also have 900 million. And also the role of the Kokoro no Care Center outreach is already introduced, but to the temporary housing, that the supporter will visit them and ask if there are any needs. And the challenge is that the starting point was very late. At the time of Hanshin, it was several months, but the East major earthquake 1 year later. Then, so we are the last supporter. So we are not acknowledged from the beginning. So what are you here for is the question we often ask. So it took several years for the community to accept our services. And it was true in our organization. The same thing has happened in Fukushima. A lot of members coming outside of the prefecture kind of gave up and left. And also the coordination with the existing organization is difficult. So these are the challenges we face. And of course, there are advantages. And a lot of funds is infused. So the manpower or the professional workforce increases. And also, it is a private initiative. So we have much flexibility in terms of the operation, and challenges are already I mentioned. So it is important to know advantage and disadvantage. And in that Great East Japan earthquake, we became very creative for the high-risk patient, like Health Management Center. We have done that outreach by the telephone call. And also the health management survey is another typical one. And also for the support of the daily life. And the temporary housing and life support counselors were introduced. So it is. It doesn't have to be the psychiatric doctors, but the basis is the support for the livelihood. So livelihood support is the basis, and there are activities by the public health nurse to support their daily activities, residents' daily activities, to provide the mental health care. So these are the points included in case of Miyagi Onagawa-cho and KOKOKARA, the life daily life consulting center. We have done this for several years in Ishinomaki. NPO set up the session and also provided the support for the people with the psychiatric conditions. And also, actually, the Hamadori was the area, there was almost only a few psychiatric health care center and welfare system existed. So Nagomi was created. And it's still, the center is still active, and this is very valuable still, as you know. So these are the new deployment or development we have seen. And of course, that the health management center and radiation related support that have been presented was very unique and valuable activities to the region. And for the Kokoro no Care Center, there are some areas that the structure was changed. Iwate Prefecture took a lead. In case of the Miyagi Prefecture, part of the employees are seconded to the disaster-affected area. And Fukushima, so district have done the work for Hamadori on a contract basis. And these are very creative activities. And Kokoro no Care Center was taking the very central role for the mental health and welfare center. But is it really the ideal situation? But is there any alternative to Kokoro no Care Center, for instance? And there is the prefectural health centers, mental health and welfare centers. And now the municipal public health nurses are taking care of the roles, but do they need to continue to be responsible? So considering the manpowers, the Kokoro no Care Center in the large size disaster, we need to have that, but can we use DPAT instead? That may be the question, but the DPAT is done on voluntary basis by the private hospitals, and there are their own work at the private hospitals, so long-term assignment is impossible. So DPAT is difficult. To use the DPAT is difficult. So this Kokoro no Care Center has a meaning. Then, is there a basis for establishing a Kokoro no Care Center? So in the early stage, the state that the disaster planning, the DPAT will act as center of activities. It says in that the regulations, but there is no mentioning about the activities in the recovery or revitalization phase. So only Hyogo Prefecture, because my center is there, in order to make decisions, and there was a council that to be created. However, in Fukushima, it says there is no mentioning of the Kokoro no Care Center for the revitalization phase. So, and so there is a concern about the same thing would happen. Kokoro no centers will be only established 1 year later. So we often use the word of a pre-disaster recovery planning, and in advance we can have the estimate or the preparation beforehand. So how to utilize that the activities in the revitalization phase has to be a part of the pre-disaster recovery planning. So in that includes that the securing of the budget, but the central, the people who take a central role, we need to be ready who should be the core personnel, the key personnel. That is also something that I personally want to emphasize to talk about the Kokoro no Care. So even if we make a dedicated organization, we need to consider if the establishment is feasible, determine organizational scale, and consult with the relevant organization. Those have to take place beforehand, before making the Kokoro no Care Center. So with that, so the tone of my presentation is slightly different from others. So Kokoro no Care continues a very long time. So these activities going forward, and it should take several decades going forward. So through this kind of idea, after the large-size disaster, for the mental issues, we need to have in advance preparation. Thank you very much for your kind attention.
So thank you very much for the comprehensive. So after the Hanshin Awaji earthquake, you mentioned about the initiation of kokoro no care, mental care, and then you mentioned about the initiation of DEPA, and I was very impressed. But the mid to long-term care was left behind. And you mentioned about the advantage and the challenges around the Kokoro no Care Center and the future discussions. Fukushima is still struggling at the moment, but we should be prepared at the normal times before the disaster. So we would like to take questions to Dr. Kato during the discussion. So we would like to park here for a moment. Thank you. So it's 5 p.m. So let us start the discussion of session 2. I would like to turn to Tsubokura Sensei, Maeda Sensei. Thank you. We would like to move on to the discussion of session 2. Thank you very much for the questions. I would like to first ask a question to Dr. Kamiya. First question. How was A-bomb survivor lifespan study leveraged in Fukushima health management survey after Fukushima Daiichi power plant accident? Thank you for the question. The A-bomb survivor lifespan study, as mentioned today in the symposium, it started roughly 80 years ago, and the impact of radiation, it was unknown back then. So the acute disorders came to light gradually, and after some time, we came to know there are some implications and indications that happens after time. And this was thanks to the scientific evidence. And ABCC, RERF studies have made it clear and evident. So once there is a radiation incident, it requires a long-term surveys. Otherwise, there are a lot of uncertainties unknown of the prefectural or citizens' health. I believe that is what we came to know from the A-bomb and the Fukushima prefecture. So even after the Fukushima Daiichi power plant accident, we found the need to initiate the survey, health management survey, and we heard these voices, and that triggered the Fukushima health management survey and the approach of the survey. Because we have the experience from Hiroshima and Nagasaki, and there's a lot of epidemiological studies. So based on the past experience, Fukushima health management system was established and put together. That's how I perceived and understand. So the Fukushima health management survey is supported on the experience of lifespan study from A-bomb survivors. So second question. There are a lot of misperception, prejudice, negative publicity persisting around Fukushima Daiichi power plant accident. So amid this situation, is there any areas the Fukushima Medical University can collaborate with RERF in terms of surveys? So FMU and RERF have executed a collaborative agreement to work in tandem. When there is a radiation accident, it's very rare. It's not so frequent and common, and it's a very tragic incident. So those affected suffer from the radiation exposure and impact. So there's a lot that we can work together. So for FMU, Fukushima Medical University, the reason why I came to FMU is thanks to the expectation of such collaborative role, and that's primarily why I was accepted at FMU. So FMU and RERF have worked together and will work together for the future to contribute to the prefectural citizens. Thank you. I also have another question, third question. Dr. Dominic Laurier mentioned about several studies of non-cancer studies. How about RERF? What is the current status studying non-cancerous diseases? Thank you very much for the question. In today's presentation, I talked mainly about cancer. I couldn't cover all the activities at RERF, so I focused and narrowed down the topic to cancerous diseases. But as in today's presentation, in 1950, when the lifespan study started, that was the very beginning. But there were additional 3 clinical studies added. In the clinical studies, we call it adult health surveys. And in this adult health survey, they target non-cancerous diseases. So cataracts or thyroid diseases, chronic liver diseases, or rare ones would include thyroid function diseases. So we found there are some new findings, and heart and cardiovascular diseases are also all in scope of the studies. So this has been a long-standing study for non-cancerous diseases as well. Thank you very much. Thank you. I would like to turn to Dr. Maeda.
Thank you. And from myself, I'd like to ask Dr. Kato some questions. Amongst many questions, because there have been some overlaps in questions, I have picked 3. First of all, Dr. Kato, so in 1995, after the great Hanshin Awaji earthquake, it's been 30 years and more. And in Kobe, there are still individuals that require mental health related cares, and there are still mental health challenges. And what are the supports being done to those individuals? Thank you very much. Post-disaster mental issues include trauma, and the characteristic of these individuals is that they cannot seek care, and they have difficulty asking for help, and they tend to take everything within them. And at one point, the limit is reached, but that point can come in 10 or 20 years after the disaster. And in my experience, the individuals who have lost their families, and they have things within them, and when they saw the reports of East Japan earthquake, and they could not bear anymore, then they finally came to me. And therefore, there are those who are persevering those issues, and there could be those with grief from the loss of families, and in natural disasters. After the separation with a family member, there are societal pressures to accept those losses, but this is a sudden loss, and therefore it is difficult to accept. And there are those individuals who still carry with them such grief, and there are those who still come to my clinic after 30 years. Thank you very much. And 15 years after the Hanshin Awaji earthquake, the Great East Japan earthquake happened, and then it's been 15 years since then. And so there are impacts still felt by the individuals, is what we learned. And another question that have been received is that today, so you have given the chronological supports, but how about the horizontal factors? That is to say, within the community, are there any differences between communities? And when those issues arise, and then what are the coordination with the local communities? For example, the Kanshin Awaji earthquake struck the metropolitan area and the East Japan earthquake. So there have been many rural communities that have been affected, and it was also combined with the man-made disaster. What are your experiences? Thank you very much. Basically, there are similarities in these issues. However, the pre-disaster structure and the system, and due to those differences, the post-disaster requirements would also differ. And in Hanshi Awaji earthquake, so Akashi, which was very close to the epicenter, the city of Akashi, to begin with, there was a local interest in supporting the mental aspect. And so they initially said, we do not need Kokoro care centers, we can take care of it. And so they did not ask for help. And when there is a good network, then they can use these existing networks. But on the other hand, if the support structure pre-disaster is fragile, then we need extra support to that. And also the quality of the disaster. For example, in case of Fukushima, there are big issues to those who evacuated from Fukushima, and the support provided to those individuals was very thin. And same thing happened in Hanshi Awaji earthquake. Those who moved from Kobe to other regions, they could not get ample support. And so after the disaster, and when we say after disaster, and there are many differences in the regions. Thank you very much. Yes, and exactly. And Fukushima, people have spread to throughout Japan after the disaster, and therefore, in our reports, so the mental health situation of those who evacuated to outside of the prefecture the impact has been higher, so we will need to consider special support to those individuals. And another point is the point that was not mentioned here, but then the fatigue of the supporters. In Fukushima as well, in 2016, we experienced 9 public servants committing suicide, 3 from the prefecture and 6 from the cities and towns. And so in those disaster-impacted areas, what are the supports to the supporters? So actually, this came in life when the firefighters and disaster relief personnel condition was gathering interest after the Hanshi Awaji earthquake, because they have suffered many violence. So they are very strong personnel, but then what we call critical incident stress have been felt by those relief personnel, and with that, the system have been established. On the other hand, those in the administration, so they have to have continuous involvement with the disaster, and they tend to be the party that receive criticism. You are a public servant, and then you are getting paid. You're getting secure pay, so that will cause additional stress on them, despite the fact that they are providing support, and they themselves are also being struck by those disasters. So when those accumulate, there could be some unfortunate cases that occur. And as I have mentioned to you, those firefighters and self-defense forces, there have been some structure to support them, but to public servants and other individuals, we still do not have a proper support system. So that's what we have to work on. Thank you very much. And we have some extra time with us. And actually, with there are connections between Dr. Kamiya and Dr. Kato. In 2004, there was a request for the survey from Hiroshima Prefecture, and a comprehensive survey was conducted. And so those in the hypocenter and those who were not recognized as hibakusha, so there was a comparative study. And during that time, so Dr. Kamiya was leading the way, and Dr. Kato was involved in the mental health aspect of this survey. And also several years ago, we got a request from the Ministry of Health, Labor and Welfare, and we did the final survey. And in that report, as Dr. Kamiya mentioned, some prejudice or stigma issues, as well as the suffering of the hibakusha from stigma. And some individuals had experienced the impact that was as major as that of the disaster itself. And so how should we address these issues? Can we hear from both of you? Thank you very much. It's a on-the-spot question.
Thank you very much. This is a very profound issue. I would like to recall and talk about the case in Hiroshima. So after the A-bomb radiation exposure, there were a lot of prejudice, stigma, and discrimination. I did not directly experience this, but to the extent I've heard, like marriage discrimination, job recruitment and hiring discrimination was persistent for a very long period in Hiroshima. And there were other stigma, prejudice, and misperceptions. And that there was a prolonged impact from those stigma. So the survivors, hibakusha, struggled and fought back to discrimination, or against discrimination, and took a long period of time to overturn them. And accurate studies hasn't been conducted. What has been done to address these stigma? To my knowledge, I am not aware there has been any studies. And in the case of Hiroshima, especially, the study on mental health, kokoro, was not sufficient immediately after the A-bomb exposure. And what's been said now, they call it A-bomb bura disease. So this person was exposed to radiation and was not working and just idle and not doing anything, and it was criticized for. But if we look back, this person could have been struggling for PTSD, severe post-traumatic syndrome. But people were just looking at the external surface and saying, hey, this person is just neglecting. So all these kind of discrimination and stigma for the lack of understanding or lack of information is something we could expect and cannot avoid. And I have been in the risk field at Fukushima immediately after the incident, but it's hard to communicate, extremely hard to communicate to the scientific results and facts. And it's also difficult for the counterpart to accept the scientific evidence or knowledge. And that leads to misperception, misunderstanding, and eventually lead to discrimination and stigma. So in that sense, it's important to share and get radiation-related scientific information well known to the public, especially for the young generation living in Fukushima. I believe a lot would be living outside Fukushima Prefecture eventually, and we want them to be equipped to fight back those discrimination and stigma. So therefore, or in order to equip them, correct information, accurate information is extremely important. So during the course of primary school to high school education, it's important we provide and equip children with scientific facts.
Thank you very much. And can I hear from you, Dr. Kato? Thank you very much. The issue of stigma is a difficult issue, and I cannot easily answer the question. But what we know from Kuroyama is that those residents of Kuroyama are saying that they are not treated as proper hibakusha, and therefore they have been discriminated for that. And many individuals mentioned that. And what I remember is that an individual in his or her 80s remembers clearly what happened then and what kind of light he or she saw and what kind of air the impact was felt, and then he or she remembers seeing the people fleeing the hypocenter. And so I was struck by how clearly the memory resides in such individuals. And from the perspective of stigma, I was struck by what Dr. Kamiya has said. And so those who have suffered stigma, to communicate is important. For example, the individuals of Nihon Hidankyo communicated their experiences that led to mitigate or alleviate the stigma in Hiroshima. And therefore, it is not for someone who does not live in Fukushima, like myself, to say this, but I think communicating from Fukushima may contribute in alleviating the stigma. Thank you very much. And after this session's entitled "The Future of Disaster-Affected Areas and Building a Brighter Tomorrow," and actually I was able to hear such relevant messages from the two presenters. And especially, this is an encouraging message to the people here in Fukushima. With this, we would like to close the discussion session of session 2. Please join me in giving another round of applause to the two presenters. Thank you very much.
So it's time to start. So let us start session 3. The open lectures for Fukushima residents. The chair will be Mr. Nolet Kenneth. Please refer to page 46 to 47. So Dr. Nolet, over to you, please.
Good afternoon, everyone. I lived in Fukushima since 2013. My name is Noret. I live in Fukushima. The first speaker is Professor Ishikawa Tetsuo, who is internationally recognized as an expert on environmental radioactivity long before moving to Fukushima in 2013. Back then, soil decontamination was still underway in the neighborhood where we both live in faculty housing. So it was reassuring to me that such an expert was completely comfortable walking to and from FMU about 2 kilometers in each direction. Today, we can all learn from his examples and his expertise. And Professor Ishikawa, please. Thank you for your introduction. My name is Ishikawa. Today, I'd like to talk about the radiation today. Since the nuclear accident, I imagine many lectures on radiation have been held. So some of you may even be tired of hearing about radiation. Even the participant through Zoom, I'd like to express my gratitude for participation and also audience here. And think about it. When we consider it, our surrounding contain various chemical substances and the known to affect health or substances that may potentially affect health. We refer to these as health risk factors. 15 years ago, the radioactive substances were released into the environment due to their nuclear accident. And also the iodine and the cesium were the only known names among the experts, but this was more widely known. So out of the various risk factors, for instance, ultrasound is already there, and we are familiar with that. And smoking is the voluntary behavior. So voluntary behavior and something already exists. We tend to see the risk of them as low. And opposed to that, we didn't have the radiation coming from the nuclear power plant, and this was released regardless of your will. So therefore, we tend to feel the radiation seems to be very dangerous and can be harmful for your health. However, out of these factors, looking at the radiation, what are the features? These are the topic I'd like to focus today. And one characteristic of radioactive substances is that they are relatively easy to detect. For example, the influenza virus, for instance, whether we have influenza virus in this room or the coronavirus in this room, it is difficult to detect that. On the other hand, amount of radiation present in this room can be measured using relatively simple devices, like the one in this photo. And based on that measurement result, it is possible to determine what extent it can harm the human body. And the microplastics, and if it is accumulated within the body, it may cause that the damage to your health. But the microplastic accumulation in your body, it is difficult to detect. On the other hand, whether you have radioactive substances, you can measure that relatively simply using the whole body counter. So considering this, among the substances that could be a health risk factors, the radioactive substance can be said to be relatively easier to detect, and we can evaluate the exposure doses based on the measurement. So I talked about the radiation is relatively easy to detect and measure. Therefore, there is, even if it is a minor amount of radiation, this device can detect that. So I showed some example of the detectors. For instance, for the food monitoring device for food, and also that measurement device in the environment, and also that external exposure. And these devices can detect the very minimal level of radiation, which have no effect on the human body. So because of this capability, so finding the radiation, it doesn't always mean it's dangerous. And that is the message I'd like to share with you. So in order to evaluate the impact on the health, it is not the emitting side, but it is important to focus on the recipient side. And please go to that. I will elaborate more on the next slide. And this illustrates the emitter and receiver slide of radiation. You can compare the two, upper one and the lower one. Comparing the upper, lower, upper, and that this can be exampled as the light. The emitter's number is like watt of the light bulb, and that is if it is applied to the radiation. So emitting side is becquerel, and it indicated by BQ, and that is on the emitting side. On the other hand, by the light coming from the light bulb, that in case of radiation, it is exposure dose. And in terms of the unit, it is described as SV, sievert. And there is also a gray as a unit, but in my presentation, because of the time constraint, I will skip the detailed explanation on that. And the example of the radioactive material, I like to talk about potassium. It is included in the food. For instance, the vegetable foods, if you look at the ingredients, the potassium is always found. And this is a certain vegetable juice, 200 millimeter paper pack product. And this indicates that ingredients, it says 645 milligram of potassium. And potassium is a mixture of three substances with a different weight, potassium 39, 40, and 41. These three substances. And 40 of the potassium has the property of emitting radiation. And in the overall potassium, even if you want to exclude this potassium 40, you cannot do that. So in the potassium, there is always potassium 40, which emit the potassium. So this is a vegetable juice example on the flat plate. On the flat plate, and 645 milligram of potassium. In that the unit of 40 potassium, it is 20 becquerels. And so emitting site unit is becquerel, as I mentioned. And in another way, per second, about 20 radiation particles are emitted. It is invisible. Radiation is invisible, but per second, 20 ray is being emitted. It looks something like this, if you are able to see that. So, talking about this, then, and some people may ask, should I avoid drinking vegetable juice, or should I get away from the vegetable juice section in the supermarket? I understand that, but what I want to emphasize is that the emitting side of the radiation, the number of ray of the becquerel, it's not focusing on that, but you should focus on the recipient side. That is more important. So, on the previous slide, using the vegetable juice for 200 millimeter, it's 20 radiation per second is emitted. So not limited to vegetable juice, and through your daily diet, you are taking potassium into your body. So it's about 2 grams per 1 kilogram of your weight. So if you weigh 60 kilograms, 3,600 becquerel potassium exists in your body. But this has individual differences. In other way, per second, 3,600 radiation particles are generated within the body every second. So if I say this, it sounds as if it is a big number, but this is the emitting side. Then if it is converted to the recipient side, what is it? So 40 exposure dose is 0.17 millisievert, and it is not dependent much on the type of food. So as I said, the radiation emitting side unit becquerel and also recipient side sievert, there are much gap. That's often the case. So I'm just showing you the example of that gap. So there is a cesium-137, and per kilogram, 100 becquerel, let's say is included in that food. It is like a standard limit of the food. So it is managed not to exceed this number. So this 100 if you eat 1 kilogram of that, and if you calculate that the internal exposure, it is 1.3 microsievert. So compared to 100, this number is much smaller, as you can see. Another example is that for 1 year, cesium-137 continuously taken, and let's say 30,000 becquerel in your body. And then if you calculate that the internal exposure and the 1 millisievert, if you hear 30,000, it sounds like a big number, but for the recipient side, and it is converted to the recipient side, it is 1 millisievert. So the becquerel and sievert relationship varies depending on the type of radioactive material. And this is for cesium-137, but even if the becquerel number is big, the sievert number can be small. That often happens. So considering the impact on the people, the sievert, the recipient side, converted figure is the basis for your evaluation. So I talked about milli and micrometers, millimeters and micrometers. So I'd like to share with you the size of that. And on the left-hand side, there is 100 millimeter, 1 millimeter, 1 micrometers, and familiar objects similar size are shown. And the postcard is about the horizontal, it is 10 centimeters. And the 1 yen coin is about the 1.5 millimeter thick. And the food wrap is about 10 micrometer thick. So 100 millisievert, 1 millisievert, microsievert, you can compare them more easily. As shown on the previous slide, 100 becquerel, when you take that amount, and it is a little exceeding 1 microsievert, so 30,000 becquerel of the cesium-137 were present in the body, and that means 1 millisievert on the recipient side. And the sievert is much smaller than the emitting side, once again. And as you can see, the sievert values are consistently smaller compared to the becquerel counts. And for atomic bomb survivors, the threshold where radiation health effect becomes clearly observable is 100 millisievert. Compared to that, you can see 1 millisievert and 1 microsievert are quite small. So the reception side dose it is important to convert in the recipient side the unit, and this is a dose and also the radiation effect on your body. And this is a simplified comparison. So there are two impacts. On the left-hand side shows you the within a few weeks after the exposure, you see that the effect, for instance, hair loss and skin disorders. So these effects emerge once the dose exceeds a threshold level. And on the right side, after several years, that impact may appear mainly in the form of cancer. And you have dose and also the frequency of the impact vertically. So natural incident rate are shown in orange. So natural incident rate can vary by region. So that the range of the variation is shown in the light gray area. If radiation become larger, it goes over the range, then you start to become the impact from the radiation. So this is very simplified graph. So it is not always this clean linear as shown here. So how much dose will give the impact of how much? There is a certain level of knowledge, and you understand you can have a certain level of estimate. Then, what was the level of the radiation dose? At the Fukushima nuclear accident. This is the left-hand graph. In the previous slide, within a few weeks, you see the impact, and threshold dose is somewhere here, and the dose is over the threshold dose, or just before the threshold dose, or much lower than the threshold dose. When we think about that, clearly, much lower level than the threshold dose. That's already known fact. And the other impact, after a few years or several years, the impact after several years. So if you come this level, and this is clearly above the normal statistical variability, so the frequency increases. Whether it was this level or within that the spontaneous incident variation range. So, which was the level? So international organization reports that the left-hand side, this is rather the baseline or the range of natural variation. So, right after the nuclear power plant incident, it was difficult to measure. So there is much uncertainty about the dose. Therefore, we do not say there was no impact, but we are conducting various investigation and analysis. So to summarize, and this is the summary slide. Various substances that may potentially affect health exist around us. Among them, radioactive substances are relatively easy to detect. And because of this sensitivity, radiation detectors can generally measure radiation down to the level that have almost no effect on the human body. When we consider the health effect of the radiation, we think of the emitting side and the recipient side. So rather than the emitting side, we need to consider the side of the recipient. So knowledge about the knowledge exists regarding the effects of radiation at a certain level of the dose. and the international organization report that the Fukushima nuclear accident didn't give much impact on the health of the residents of the Fukushima prefecture. However, we would like to continue to do various surveys and investigation. Thank you very much for your kind attention. Thank you very much, Professor Ishikawa. Next presenter is Goto Aya, Professor Goto Aya.
With family in Yamagata and Gunma, she could have easily evacuated. But in a shared decision-making process that included her school-age son, they decided to stay in Fukushima City, teaching, learning, and living. Professor Goto, the floor is all yours. Thank you very much for your kind introduction, Professor Noret. Thank you for inviting me here today from the United States. I'll be discussing, but I will not be speaking about radiation. I will not talk about radiation. I'll be discussing how to use health information. And right off the beginning, we're encountering the term health literacy. According to Dr. Shimabukuro, he used the word health literacy, kenko literacy. My goal today is to convey at least a little bit of what health literacy means. My specialty, or my field of expertise, is, as in your handout material, it's public health. Together with public health nurses, we diagnose not individual patients, but entire communities by reviewing health statistics and survey results. Based on these findings, we prescribe methods for health promotion. In this context, health information serves a role similar to medicine. As a specific activity, I work to designate the area around Fukushima Station as a smoke-free zone and communicate that information. Please look for the signs and road marking preventing second-hand smoke exposure on your way back. There are signs and signages on the road, so if you would kindly pay attention to them, I would very much appreciate it. So, in 20 minutes, I'll introduce health literacy, then discuss tips for improving your health literacy, and tips for communicating with doctors and nurses, and tips for finding health information. So, health literacy as a borrowed word. Health literacy is defined by the World Health Organization as the cognitive and social skills which determine the motivation and ability of an individual to gain access to understand and use information in ways promote and maintain good health. However, medical terminology is difficult to begin with, and recently new terms like metabolic syndrome and frailty have come to people's attention. Given this situation, it has become recognized that health literacy is not just about whether residents and patients can use information, but also requires healthcare professionals to make efforts to communicate clearly. That's why Dr. Rima Rudd from Harvard, pictured on the left here, began training healthcare professionals in communication. She has also spoken at this international symposium before. Health literacy requires effective communication between those conveying information and those seeking to use them. It is essential to move beyond healthcare professionals unilaterally delivering information and individuals passively receiving it, fostering mutual communication instead. For example, this is an entrance to a university hospital outside Fukushima Prefecture. There are various information posted here, and there is someone standing a guide who is standing by to provide tailored information to each visitors. If there is a person like this, it's important to ask questions of the person responsible for conveying this information if you don't understand something. But unfortunately, Japanese health literacy levels are reported to be low compared to global standards, and it's not known why. When examining detailed indicators of health literacy, a score above 33 is considered sufficient. Blue is Europe, and you can find exceeding a score at 33. And compared to other Asian countries, you see relatively high scores close to 33, but Japan is substantially lagging behind, lower. And so let's look at what health literacy actually is. Health literacy is said to have 3 levels. For example, if you have hypertension, high blood pressure, and need to reduce salt intake, actively receiving that information marks the first level. Now, if you need to suppress and reduce the salt intake, the person might start researching cooking methods or discussing with family about what kind of meals to eat to cut back on salt, and that will remark the second level. Finally, actually starting to cook using those methods mark the third level. The assessment of the second and third levels can be confirmed by asking and answering these questions. Let's take a look from the top one. Can you gather information from various sources? Can you choose and convey them? Can you determine which sources are reliable? Can you utilize the information? The average score for Japanese people is 3.5. So most people tend to score around 3, or occasionally get a 4. The challenging part are the bottom 2 items. Consider the credibility of the information and make decisions based on the information. And you actually put them to practice. That is the hard part. So on-site participants, perhaps not necessarily for online participants, but Fukushima City aims to enable its citizens to utilize this most challenging aspect through its municipal health promotion plan. Looking at the actual citizen survey, most people can gather information, as seen at the very bottom. And blue color represents respondents saying, yes, I can. And you can find most people can gather information. But only 70% say they can effectively utilize their gathered information. And underneath, you can find consider the credibility. Determining whether it's trustworthy seems even more difficult. Now let's examine the relationship between health literacy and health. Low health literacy prevents adequate prevention, leading to worsened health conditions and mortality. Conversely, high health literacy enables appropriate disease prevention and disease management, resulting in improved health. What's even more interesting is that when patients have higher health literacy, their satisfaction and trust in healthcare services increase. This is likely because they can better understand their own situation and communicate their preferences, allowing healthcare providers to offer services tailored to their needs. In other words, actively communicating with healthcare providers is crucial. So regarding communication methods, I'll introduce 2. The first is Ask Me 3. This is a technique called Ask Me 3. When patients confirm things with healthcare providers, the three most important points are listed here. We encourage you to proactively ask these three questions. What is my problem? What do I need to do for treatment purpose? What do I need to do for treatment? And number three, and why is it necessary? How would I benefit from such action? And how would I suffer or face difficulty for not doing such action? The second is teach back. Recently, healthcare providers have been advised to ask these questions. After providing explanation to the patient, question, how would you explain this condition to your family? Number two, please explain how to use this medication. I want to confirm if I explain things clearly. So tell me, how do you take this medicine? If you receive such questions, please respond proactively. The reason why I say this is because research shows that health literacy level improve when individuals answer questions posed by healthcare professionals. It is also true that researching health-related topics, discussing them with others, and applying the knowledge to one's daily lives help improve health literacy. So let's talk about tips for researching information. Try selecting information that's easy for you to apply in your daily life. For example, a nutrition program recommended by U.S. government agency lists 3 key points for reading product labels. Point number 1, focus on the top ingredient, because this is most contained in the product. Number 2, avoid buying products with long ingredient lists. Number 3, avoid glucose. Let's take a look at a real label. For product A and product B, A has a longer list of ingredients with sugars coming after apples. And for product B, it says apples only. So you should choose product B. Now this is another example. Product A. This is tofu. Product B has more ingredients with salt coming after soybeans. So it's better to choose product A. So after learning this, I immediately checked the ingredients of chocolate. Well, I shouldn't be eating so much chocolate, but I found sometimes the main ingredient of chocolate products is sugar. Next, let's talk about workouts and exercise. And the popular topic is steps. While we often hear, let's exercise, it's hard to grasp a clear benchmark. Lately, the easily measurable step count has gained attention. For those under age 60, aiming up to 8,000 steps per day. And for those 60 and older, aiming for step counts to 6,000 steps per day is recommended and encouraged. After hearing this, I count my steps, and I manage about 4,000 steps a day at most, but I intend to at least keep up this level, because the more you walk, the more your risk of death gradually decreases. So even a little walking is important. So these are easily understood, straightforward information So beyond selecting information that's easy for you to use, please also pay attention to these points. Number one, who wrote this information and for what purpose? What we often see is that they want to sell a product to the audience. So these kind of promotional or advertisement should be taken into account. And what is the source of the information? Is it just a personal opinion based on personal experience? Nutrition Explorers, I mentioned earlier, is a U.S. government-related organization. Of course, if you trust U.S. is another question, dependent on individuals, but the credibility of the information or trustworthiness of the information source is another point to consider. And then, when the information was published, is it outdated? And after investigating and doing your research, if you think, and not sure, it's also necessary to compare them with other information. Please hone your skills in using health information to promote your well-being. And that's how I also live my life. Thank you for your attention. Thank you, Dr. Goto. We are approaching the final part of today's symposium. Thank you for participating until the very end.
With this, we close session 3, open lecture. Next, FMU Director Otake Toru will deliver the closing remarks. Director Otake, please proceed. Thank you very much for staying with us until the very end. My name is Otake from FMU, in charge of FHMS. As we conclude the symposium, it is my pleasure to offer my closing remark. On behalf of our university, to the many individuals who provided the support and cooperation for the successful conclusion of the International Symposium on the Fukushima Health Management Survey, I would like to extend my sincere gratitude. At this symposium, we were honored to have experts from Japan and abroad take the stage and share invaluable insights of their respective fields of expertise. Furthermore, the discussions prompted by questions from the participants provided a meaningful opportunity to deepen the understanding of the Fukushima Health Management Survey and the current situation in Fukushima. In session 1, faculty members from our center provided detailed explanations of the findings obtained from the Fukushima Health Management Survey, including the basic survey, thyroid examination, comprehensive health check, mental health and lifestyle survey, and pregnancy and birth survey. In the keynote lecture, Dr. Dominique Laurier from the French Agency for Nuclear Safety and Radiation Protection introduced the latest epidemiological research on health risks associated with low-dose radiation exposure. In session 2, experts from outside of our center shared their insights. Dr. Kamiya from the Radiation Effects Research Foundation focused on the health effects of the Hiroshima and Nagasaki atomic bombings, while Dr. Kato from the Hyogo Institute of Traumatic Stress discussed activities to protect mental health after disasters. And right now, session 3 took the form of an open lecture to convey necessary information in an easily understandable way, presenting on radiation and health literacy in an easy-to-understand manner. Our university remains committed to supporting the health of you all through the Fukushima Health Management Survey. Furthermore, by deepening our collaboration with the wider world, we aim to contribute to the Fukushima's recovery and the creation of its future. In closing, I would like to once again extend my heartfelt gratitude to everybody who participated in and supported this symposium. I also ask for your continued understanding and cooperation with our university. Thank you very much. Thank you very much, Director Otake. This concludes the 2026 Fukushima Medical University International Symposium on the Fukushima Health Management Survey.